All right, so this is what we're going to talk about, and pretty much this model is going to be based upon what Richard and I have been doing for however many years it's been now.
Well, how long have you been in Montrose? 5 years?
I've been in Montrose 5 years, and we've been doing it long before that.
But I mean, so it's actually being in the same location for 5
Yeah,
years.
right. It's only since I moved to the current location that we've really done the in-office, because we had no facility for him before, which we'll see. So let's go through it, and this thing's going to work. Okay. So in the past, and this is as of a couple of years ago, whatever, this is what we were dealing with, where it's just pretty much the two of us dealing with all the issues that we had to deal with. And my orientation, of course, is doing the orthopedics with orthotics at night, orthotics during the day, whatever the case may be, whatever the patient needs, and feeding off of what he's feeling and sensing. And we communicate in some fashion or whatever, but in separate facilities. So the disadvantage is when a patient comes in and they are still symptomatic on an orthotic that I'm preparing for them, then it's, okay, is it my turn to play, or is it my turn to send the patient over to Burbank to see Richard? And this is the one thing that long before I met him, I was doing a lot of orthotics, a lot of TMJ treatment in the past, and it's always about the plastic. I'm always battling, how am I gonna get rid of that little pain they have in their joint, or that neck problem, because something's obviously wrong with my orthotic. Okay. So we tinker and we tinker and we tinker, and that's what this whole paradigm helps to eliminate, is a lot of that tinkering, because I'm gradually learning that when is it his problem to fix, and I leave my plastic alone, so that's made it a lot easier. Okay. So this was the result, is that either it takes a long time or we don't get the best result. We don't uncover some of the other issues that are going on with them.
And just like and one of the things is that with Olmos' model, it was 5 years ago or 6 years ago when he started doing those residencies. I came down the first year after he came here and spoke, because he was trying to figure out what this chiropractic stuff could do for him, because he hadn't had any chiropractors that really helped him yet. And so when I went down, I did the whole cranial thing on him, and it was instantly, this is how you make it easier. And the reality is having that feedback that, how do you release the system to the orthotic, because the system's in that sympathetic overload or that state of stress. So it just made a whole nother step, or another whole leap forward after that, because of that relationship. And it's really
just don't kick the can.
Clients need to be checked cranially to make sure that it matches. And if it doesn't, either you can release the system to the appliance, or you need to change the appliance to match the cranial function, which is a little more Nordstrom's model. But if you're doing the neurology, you're actually coming close anyway. So that it really is made, from what I can see, in Nordstrom's model it was essential from the beginning, and now it's becoming essential in the dental TMJ and neuromuscular, not neuromuscular, but the motor reflex type of work that Olmos teaches.
So where we've progressed from there, as we've started working in-house and everything, is that we've also been working with Dr. Nordstrom and Dr. Moreno, the osteopath, who you heard yesterday and the day before. We've included some other therapists in the system, and obviously the results is that you have a higher success rate. You travel through things a lot faster and easier, because it's not about your plastic anymore. It's about some of the things that may be emotional things, that may be past history traumas, things like that. And these other people help us figure all that out. And so a lot of times I'm just kind of reduced down to a mechanic, and which is kind of nice, because I get to turn my brain down a little bit. I don't have to work quite so hard. Okay. But the other part of it, from what we get at the bottom end of this, of course, is that now that we're working in a network, all these people are referring to me, and I'm referring to all them, and so it's a whole paradigm that works well for everyone.
Do you have a slide about the DCO group in here? Did you put a slide about the DCO group?
No, I don't think so. I'll have to watch and see. I can't remember now. Okay. So, and then we're going to talk a little bit about the future, and of course that is that as our study group, okay, which is what he just mentioned, which I don't think I put a slide in here about them, and that's part of what we did is that even before I left my old office, we got a study group going because once he and I started working together, we realized that, boy, there's a lot of information. You know, everything you learn, you realize there's more that you don't know and you don't understand, and so you have more questions, and so we need more resources to answer those questions because...
Okay, so the study group is the osteopath and the chiropractor?
Right, the study group is a multidisciplinary group and include all those people.
What started off was, what we did, he started off 10 years ago being just dentist and me and a couple chiropractors trying to get more chiropractors in the group and get more dentists that were referring, so it was like I was trying to teach them what I did, and they were trying to, you know, figure out each other what they were going to do. I think it was really early on. But in the last 2 years, it's turned into a practice management tool. It's really become a kind of a lay lecture. We get people, like the patient came in, they'll just come in because one of the practitioners invites them in. And so now we've got practitioners, speech pathologists, all kinds of people that want to come see what we're doing now because just the network has grown. It's like, oh yeah, these guys, you know, they have this weird thing they do. But they want to be part of it now because the oromologist, the speech pathologist are more regular than any of the dentists. Him and I are the two of us long-standing people in it, meaning that it became just strictly a meeting about our dental cranial program, and a couple of the other dentists come in and out, the oral surgeon comes in and out, but we're the core of the thing. It's always has been his office, and now we just moved into the hospital nearby. So to me, it's become the best practice management tool I've ever really had, and for this model particularly, I think it's really a good way to do it because it just has a very low-key sales or promotion about it because you're trying to teach people and they're coming in and presenting. The oromologist will come in and present what they're doing. The cranial sacral therapist came and talked about what she was doing. The oral surgeons presented, and so everybody rotates through and anybody who wants to present can present. And we all learn something. That's the oral surgeon stuff was like watching the video, all the slides of the oral surgery. It's like, okay, I don't want to do that. I'm just cutting up the face in the middle of a force procedure. So it's really, I thought he was crazy to keep the meeting going for that long because we lost all the dentists, and all of a sudden I realized, wait a minute, it turned into something that's really better than I could have ever imagined. Yeah. And most because he kept persisting that we should be doing it, and I didn't really, I was like, there's nobody left to teach, and we're not really learning from each other anymore, but all of a sudden it exploded into this whole new arena just because we kept doing it. Yeah. And it just grew on its own almost. Yeah.
Certainly as a practice management tool for developing a referral base and everything. The study group is an excellent way.
We have people driving in from Camarillo, Ojai. They've driven up from South Orange County. Yeah. So we've had people drive 50, 70 miles to come to the meeting.
But they only do it once.
But still,
if you're coming that far in LA at rush hour, you know, it's 2 to 3 hours.
But still, it made the network grow. So it's really, I think, should be part of what, if you're going to do it, try to do it, because I never liked doing lay lectures. I never liked having meetings and trying to hustle people to come to teach them about what I do, but it's exactly what this turned into. But it did it in a way that was so, it was seamless. It was just like, yeah, we're still learning it, so people actually coming in to try to get us to send them patients. But in the process, we just grew our network, our referral base, because they go, oh, because that Michelle Razor case, when I showed on Thursday, we were at the meeting, and it was, he brought her in, and it was like, okay, what are we gonna do? Let's see, and everybody, I mean, I'm talking about everybody took off and did their analysis of her before I ever stood up and said, okay, let's see. And I knew if I put the belt on her, that was really gonna be a big deal, but I knew the orthotic was part of it too. So it worked out better than I could ever plan it, because that was completely unrehearsed, that whole video, because it was just like, I think that's it, here much. And we ran with it, but God, everybody in the meeting was like, what did you do? I mean, it was like you could just see the faces just change. Like to know, I knew something before, now I know nothing.
And that is another advantage, and occasionally we do that. And when I first heard about this lady, I go, okay, this is, you know, she's got way too much stuff going on for me to take her on, especially when she's going to travel, you know, 2.5, 3 hours to come see me. Okay, and so having a group like that, you just, you know, your level of confidence in being able to help that patient, whether I wind up doing it or whether somebody else does, doesn't really matter, but all it does is it just raises the self-esteem of the group as a whole, as well as all the individuals in it.
And on the line, everybody keeps seeing how structure, whether it's dental or the two of us or the chiropractic part, that structure keeps being fundamentally part of every case, that it's really dramatic. So it sells itself. I mean, they just kind of go, oh yeah, okay, that's really, okay. They keep nodding their head. I get it.
Okay. So this is pretty much, this is pretty much the present state, and this is obviously our future, is just continuing to do these things, learning, from all these people that we see. And in fact, our next meeting in November is going to be presented by an orthodontist down from Orange County who specializes in what he calls terminal cases. When everybody else has given up, he's the one they go to. And we're going to hear about birth to 5 years of age only from him. How many orthodontists treat kids less than 5 years of age? So,
But how many of you?
yeah, how many of you are there? Not very many.
And count the clones.
Right. Yeah, it's not very many. So, okay. And then this is where I think we really want to go in the future, is that, once we've got them physiologically stable, we've got them out of this, mode of this chronic pain and all that kind of stuff. Well, they feel a lot better, but they're still not, whole again. They're still not completely there. And so now we take a look at some of the other modalities, some of the other therapists that are out there that can help enhance, their physical and mental well-being. And that's and to take them to whatever level the patient wants to go to. Okay, so why co-treatment? And I think already we've touched on pretty much all these points already here in just our discussions. It's it's pretty plain and obvious. It simplifies things. It provides us access to these different markets, because we've got all these people in this arena, whether they've come from the study group or they're actually in the group that's actually treating an individual patient. Right now, I've got one lady that I'm treating that we've got 2 dentists, an oral myologist, an osteopath, a chiropractor, and Kathy Lippman, an environmental medicine specialist. Okay, so this lady's got 6 people working on her, and I mean, this lady was headed for the suicide ring, and now she's not even thinking about that within just a very short period of time. But I know that by myself I couldn't turn that around that fast. I know that probably with even 2 or 3 of us working in that group, we couldn't. And so it makes it a little crazy in a way to be shuffling with that many people, and especially having 2 dentists on board. But we're kind of doing that really more as an experiment, because he comes out of a totally different model than I do as far as correction. And so we've kind of talked and agreed we want to stay on board, because I want to learn more about what he does and how he does it, and vice versa. And so again, there's more learning, and that's what this is all about. Okay. And this one here, the last one, this is probably the best one of all, and get rid of the limitations we have in our treatment is so important. Okay, now I know what to do when we hit that wall. Okay, send them down the street, send somebody else.
And part of that too, if you talk to Derek Nordstrom, he'll tell you one of the things he loves about Hollister, but he hates what he doesn't have a big enough network. He can't get enough doctors, chiropractors, other people that work with him. That's part of why he travels so much. He travels to osteopathics office and works in their office treating them, their family, and some of their patients. And that partially because of that, he doesn't have a network in that small a town. And so he makes comments about how great it is, what we really have in our network, because we have so much access to your clients.
Yeah. And that's part of the reason, I think, for those of you who got a chance to see him the last couple of days, I think you realize you were listening to somebody that's pretty special. He is. Yeah. But one of the reasons he is so special is because when you practice an environment like that, he has to play all the roles. Okay, we don't have, and he tells me all the time, because he's in my office every 3 months, and that's one of the reasons I do a lot of ALF therapy, because I've got the master in my hip pocket every 3 months, and that's a big advantage. And when you're doing that kind of stuff, you really need that. ALF is really, there's a lot more to it than it really looks like on the surface sometimes. So it takes you a while. I'm sure Rebecca knows that too.
Well, my learning curve was about 7 years.
Yeah, right.
Until I felt comfortable.
Yeah.
And then, I've been at it for like 15.
Right. Yeah, and I know even for myself with the ALF, when I first started working with with some of the earlier cases, especially with the kids, where the inclination is to use a banded ALF so it's cemented in place. One of the things I was doing at first was going through the pains of putting the ALFs in and not cementing them in, because I wanted the ability to take it out, make those bends in my hand so I could see what that wire was doing before I put it in.
Little sheets.
And then you put it back in. So I used a lot more cribbed, ALFs at that time. But there is a learning curve with those things. And so once you get to the point where then you start adjusting it in the mouth, and then you take it out and see what kind of a pretzel it looks like that you've done, and realize, oh, okay, well, I think I spent probably 2 to 3 years doing that before I use cemented ALFs. Leave them in, just adjust them right in the mouth, learn to feel the head a little bit, and the work goes on. Okay, so this is one that's been stated a lot of times before, and I think this is the one thing that that really got us going, is that we realized, and I think this was promoted. Even we heard this from Jim Carlson, and we heard this from people before us. That the cases that are really difficult dentally sometimes are just no-brainers for the chiropractor, and vice versa. And so obviously that made our ability to work smarter, not harder, really go to work. Okay, so. Again, we've gotten kind of ahead of ourselves with a lot of this stuff, and so it may get a little bit redundant, but obviously working in the co-treatment, the benefits to the chiropractor, like I say, we've stated most of these. Access to the patients, benefit from the advertising budgets of dentistry, which are usually much larger than chiropractic. That's interesting. I think basically because this is Richard's slide, I think basically what this says is that because I put on the study group and I go through all the expense, all the preparation, all the work, and he gets the benefit.
And Razi does huge marketing. He goes out and he does his lunchtime lunches with dentists and oral surgeons, and I just show up and what do you got for me?
I know. Yeah.
And then the ones that live anywhere between his office and mine end up getting referred to my office anyway. So the benefit really is that, because it doesn't matter who I'm working with, they're doing more marketing than I am, because I don't have to really do it, because for me personally, I've created a lot more dependence on me because there's no one else to work with. So for me personally, it's like I'm not spending money to advertise at all, so they're spending 10 times more time than I spend.
And the last one, for both the practitioners and for the patients, there's a lot less stress, because right off the bat, the effects they get from treatment is so much more dramatic, and the story that they're getting from everybody involved is kind of the same. So, they tend to be kind of impressed that everybody's on the same page and that we're all seeing the same things. And what we tell them is not, oh yeah, man, you're going to love this piece of plastic, it's going to make you feel so much better. What we're going to tell them is just plain old common sense, why they're having the problem they have, how we're going to help them to get better. And they go, well, that makes sense. And that's frequently, I'd say that's the most common response I get to the information I give a patient. It says, well, nobody's ever told me anything before that really made sense. And they get that from all of us, because we're all basically telling them the same thing. Okay, there are a few benefits to the dentist. And again, I think we've already touched on most of these things. Certainly speeding up, my time in the office makes it easier. Also, there's one of the things that's happened with me anyway, is that in adjusting the orthotics, especially on my nighttime orthotic for them, we've really been able to, through the feedback that I've gotten from Richard and some of the craniosacral therapists and from Jorge, the osteopath, that they can tell us what's going on with that orthotic, and I've been able to translate that into a specific criteria for where the tooth contacts are and how they are in this orthotic. And for example, this appliance that I use in my nighttime captures the upper teeth on the outsides of the teeth. So you would think it would tend to lock them into extension, which is generally the way they come in, and that's part of their problem, is most of the patients tend to be locked in extension. Well, this appliance, even though it captures the outside of the upper teeth, the way we've developed the functional occlusion on it, okay, it will actually drive them into flexion, okay, when they swallow in the appliance. So it actually gets them moving, okay, even while they're sleeping. It's got an impetus to keep them moving, and only through feedback from them were we able to figure out how to do that. And my staff now does that, okay? And so that's taken more stress off of me, because I go, oh, well, you know, it's waking them up in the middle of the night. I go, okay, you know, it's locking them up. It's not, they're not moving. That's what's waking them up. And so I just, Christina, go do your Blue Moose thing, and she knows what to do. Okay? So it's been able to simplify a lot of the adjustments that we make such that we can even pass them on to staff.
You guys understand that about the fixed appliance? That your fixed appliances generally catch the outside of the teeth, which is on that lecture Thursday, everything is about the extension pattern, so it's not flaring. So when I started doing that lecture, all of a sudden it started clicking with Bruce especially, and something else, that you don't restrict it moving out, you only restrict it moving in. So that the fixed appliance works a little bit like a functional, because it's promoting the proper expansion. And I think the Moreno and the ground therapists at first were like, they didn't like the appliance until he kind of got, oh, wait a minute, if I just do this, then they all think it's okay now.
I know. Yeah.
So
I know. Now they're all telling me,
yes.
hey, make him one of those things. Okay.
Yeah. And
Because,
now,
yeah, it was actually one day that Jorge was there that, you know, he was trying to explain to me what it was that I was doing, and I go, okay, well, if that's the problem, then we need either trash the design or we need to modify it in some way that'll make it work. And we actually got it working so well that one of Brenda's patients that we were treating, she called me up and says, you got them locked in inflection. And I'm going, no way. She goes, they are. And so I said, okay, well, bring them in, let's see. And I locked up the occlusal, you know, inclines to a point where it just blew them out in extension and just stuck them there, or in deflection rather. And so all I do is just flatten down the inclines a little bit, and the mobility came right back. So, but again, how would we as a dentist, okay, unless you can feel it, which most of us don't, okay? I mean, we weren't trained for that. How would you ever figure that one out? Okay, I mean, that one would drive you crazy. Okay, everything's perfect. They're breathing better. They tell you, I breathe better. You know, I feel better, but it wakes me up at night. Okay, and it shouldn't be waking them up. It should be just send them off to Never Never Land. And so, okay, so let's see what else. Okay, so now we're going to talk a little bit more about, you know, where we've gone into kind of our next step was to go from shuffling them back and forth from my office to his office and back again. And obviously, as we just talked a little bit about some of these advantages, we just touched on a major one, and that is that when we've got the therapist that can feel what's going on in your office, and we're talking about from the dentist point of view now, now you can tell me what's wrong. Like when Brenda was there, she goes, hey, they're locked out in flexion, and I'm going, oh. Well, I had to think about how I manage that one, but once you've got it figured out, now all of a sudden it makes sense. And once you do your adjustment, she's right there to tell you, no, you need a little bit more, or, you know, whatever. And that's been my experience. Also, a very similar case working with Jorge one time. I had a young lady who could not go to sleep at all with the appliance. She says it feels great, feels fine. She just, it's like an awake pill. She just could not go to sleep. So I said, well, you have to come back on a day that Dr. Moreno's in the office. So she did. He laid her down, put his hands on her head. He looked at me, he says, you need to take a little bit off on that back corner right there. And I'm going, okay, whatever. She looked at me like, who is this guy? I mean, how do you feel somebody's head and then know where to adjust an appliance? But that's, those are things you have to learn when you start working, you know, in this treatment paradigm like we do. You have to learn to trust them because they know a lot more about that kind of stuff than I do anyway. And so I went back, I adjusted the appliance, put it back, and he goes, a little bit more. And then she really thought he was nuts. But the next morning she called me and says, you're not going to believe this, but she says, I don't remember hitting the pillow. So I'm going, I will never doubt him again.
That's something that happened too. That Bruce we did a couple of courses, and he did help me, and it's like, it's just a brick. All the dentists that we did that brick. But in the last year or two, he doesn't necessarily feel the cranial rhythm, but he can feel the change in tension. You know, because the cranial rhythm whole system softens. So he can actually go, oh, that's better. He can feel the change in tension now. So he's not going, oh, yeah, here's the expansion. He doesn't have that sensitivity, but he definitely can go,
yeah.
See if you think, yeah, that was good. He can actually tell it's like, that was a good one, without feeling totally the cranial rhythm and doing what Derek does. So there's a degree in which that he works now, which is much better than what it was 5 years ago, or even 3 years ago. I mean, 3 years ago with him, the last year or two, because he's got the osteopath, he's got me, and the craniosacrial therapist. He's getting feedback on weeklies on somebody. You get feedback all the time, and he's kind of feeling going, hey, wait a minute, yeah, okay, I got something there.
Yeah.
I don't know what it is, but I got something.
Actually, it was 5 years ago, because it was the last time we were here in Vegas with Derek and Jorge that we were doing some demos on some people from the audience, whatever, and Jorge called me over knowing that, you know, to me it was just the big
brick.
block of wood, the brick, and he said, sit down, and so I think he understood I was not going to feel that, so he had to find a better place, and so pretty much I feel the back of the head, and I just feel I can kind of pick up the imbalance in, I guess it's a strain pattern or whatever from the adjustments I make, and I've learned how to balance that out. And usually if I do that and then I have him or Jorge take a look, they'll come in and they go, no, they're fine. So
Or it's a real minor.
yeah,
So something
yeah,
like
it's,
that.
yeah, it's pretty close. So anyway, so obviously, you know, the advantage of having somebody right there giving you this feedback on stuff that you can't feel yourself. Now, you know, if you're Derek Nordstrom and you can feel it all yourself, well then fine. But even Derek, when he's working with Jorge or he's working with the other osteopaths, he depends a lot on the feedback that they give him. So.
And in some cases, Derek will say that in some cases he has to have a second set of hands because they're just too confusing.
Right.
So it's, some cases it's great, all along, other cases it's like, no, I gotta have help still, even now.
And I find that's one of the things that I've watched Derek and Jorge do this, and Derek will go in with his fingers, he's going to adjust the alpha plants, he'll mimic with his fingers the kind of pressure that his ALF could apply, whether it's like pulling forward on the anterior teeth or laterally on the premolars and molars. He'll mimic all those forces, having Jorge sitting there holding the head, tell him, yep, nope, nope, yep, what, and then you figure out which one, because a lot of times I've found, and this is nothing about the alphas, you learn the hard way a lot of times, is that you've got a kid that needs a lot of AP development, okay, but until you release them laterally, they're not going to go. And so you can just wind up distal driving molars instead, because that premaxilla is not going to move until you laterally release them. And how are you ever going to get that done unless you've got these people sitting working for you? And so this is, you know, that's the advantage, number one right there. Communication's immediate. Now they tell you right now, nope, not that way, or yep, that's the way we want to do it. Okay, and again, you know, that just increases the, you know, your compliance with your patients, because the patients really get a sense that when you're working together like that, that this is what it's all about. These people are really trying to take really good care of me. They have one motive. They take longer. They work harder. They spend a lot more time. We get things done more effectively that way.
Your last one, the last slide, talking about that with the staff.
Well, this is, you know, this works two ways. One is that a lot of the staff have been, you know, treated by Richard, and one of the things that is tough, you know, for us dentists, especially if we get, you know, a new staff member that is living in the traditional medical model, you know, they've never seen any of this stuff before, and they look at us like, okay, what on earth is all this about, you know? And so it takes them a while, you know, to kind of buy into some of the things we do, and all it takes is for them to get one issue resolved. You know, I know when Maria, you know, saw you for the intestinal stuff or what, the GERD she was dealing with, it's like overnight, it's just like, just totally changed her approach to what she was doing in the office. And then they turn around and become your disciples, and so now, you know, they're anxious to get involved, they're anxious to help, they're anxious to help the patient understand all the stuff that's going on.
To me, that's one of the biggest unquantifiable things that happens in the dental office, because the psychology office changes, and so if there's a question, the staff automatically is more positive, so the patient can't question, because they'll question the dentist, but when the staff goes, oh, no, these guys, you know, yeah, they heal, the chiropractor, they'll get to you. It's like, don't worry about it, just relax, you know, because the doctor walks out, and of course the staff will get the question. And you don't know what they're telling them, and a lot of them, I've had them in dental offices where they're like shaking their head going, I don't know, you know, and 3 months later, all the staff's going, this is cool stuff, you want to let them, yeah, go ahead, no, they'll take care of it, you should see what that chiropractor did, oh, you should see what that osteopath did, because they've seen it and felt it. And talk about making your life easier, because if your staff's doing that, then you don't have to do it, because it's done for you. And that's the thing, the big thing that's happened at Bruce's office, at Shirazi's office, in Tavasian's office, and then they all are like, okay, you know, the staff's like, can I get treated later? So when they're saying that, the patients are picking that up. It's like, oh, okay, this is really, you know, what I want to do.
Right. Another thing, it was mentioned before, but the issue about faster resolution of cases is that I know, and I haven't documented this or, you know, like charted or anything, but when we start, you know, a pain patient, a TMJ patient, whatever, basically the protocol is, you know, nighttime orthotic, transitioning into nighttime and daytime orthotics, at being treated by Richard or someone, usually Richard at the same time. And they always want to know what the time frame is, and I tell them, well, so we're probably looking at about 6 months before we get to that point where we should expect to see you symptom-free and physiologically pretty stable and ready to go on to phase 2, which is our orthodontics or crown bridge, whatever we do, you know, the restorative phase. And well, I'd say we probably haven't had one go 6 months in a long time. Okay, they respond so much more rapidly and so much more predictably, and that's probably, you know, the biggest benefit. And of course, when they respond quickly, then that makes them feel better faster, and then you've got a lot happier patients, and that's what we want to do. Okay, so you know, obviously to do all this, chiropractors have to have a base of knowledge and understanding, and this is a big part of it. And that's why we're here, because SOT seems to be, you know, the chiropractic paradigm that fits this model really, really well. I mean, it's all based upon understanding the whole body approach. In fact, that's how we originally got together, is that he, through another connection, called me and says, hey, do you move jaws? And I said, yeah. He goes, good, let's go to lunch. And that was, I don't know, 10 years ago or whatever, and we've been doing this.
It was 10 years ago, like the internet.
Yeah.
And he said to me, so you're one of those guys who can move the bones around the head?
So we had a rather interesting lunch. Okay. So they need to know the SOT, the cranial therapy, the TMJ mechanics. Then of course they need to get educated on what I'm doing, what my orthotics are and aren't doing, and so what kind of support they're going to need from me and vice versa. And as well as after a while, because we start entertaining all these alternative therapies beyond that to help resolve some of the other issues, that they need to become familiar with some of the other things that are done. And we're starting to use more and more of these modalities like cold laser therapy and and Prolo and things like that.
The one thing about, I don't know, for the dentist, that the reason that the SOT fits well isn't just because it's a cranial technique, is that when we teach, it's all about the planes of fascia and how you balance them, but it's also all the soft tissue diagnosis. So if you've got stress patterns that are soft tissue-wise, the patients are being not trained, but shown that how much is tied up in their stress pattern. So the CMRT up here, which he puts in there, is chiropractic manipulative reflex technique. That's an organ reflex diagnosis, so that every organ has reflex patterns neurologically back to the spine. So if you have an upper right shoulder pain that won't go away and you keep doing all the musculoskeletal treatment and it doesn't seem to resolve and you're caught on a loop, I automatically go into the CMRT mode, because I'm looking for diagnostically what's making that reflex. And it's always nutritional, it's always a weakness, it's adrenal, it's liver, it's gallbladder, it's heart. And then, that's part of taking the whole paradigm to another level. So that's what he does it automatically when we train them, because part of getting their certification is they have to do extremities. So that means you're doing foot orthotics and knee stuff, so pelvic lining of balance becomes much more complete, but also then the soft tissue stuff gets taken care of, because when you start doing the organ reflex work, then it's like the acupuncture or the stress patterns that get tied up in the system have to be neutralized or gotten rid of, so that you can break the rest of the pain patterns and the muscle guarding patterns that restrict the cranial motion and or your orthodontic / orthopedic changes. And that, because if you look at acupuncture, like gallbladder meridian is where it's all around the TMJ, if you look at the chart. So you can either send it out and you'll have an acupuncturist, or you have someone actually understands the dental work and actually get it to release. And it's nutritional and it's soft tissue. I mean, that's part of the CMRT stuff. So that's in there because I use it a lot for pain control. When a patient said aren't cycling through, and I come up with whatever they need to deal with. And of course, when you're saying sympathetic overload, you're doing a lot of adrenal stuff, and then because that's really doing a lot of gallbladder, got a lot of liver stuff because they're caught up in these patterns. So it's very important for the model.
Okay, and then likewise, the dentist, he has his work cut out for him as well, or she does. Okay, and obviously we need to be able to diagnose, the issues that the patients come to us with, and prescribe the appropriate treatment, and to choose the appropriate team that's going to help them resolve this particular individual's issues. Okay, and one of the things that gets involved, like Richard said, frequently he winds up managing the case, and that's a lot of times that's probably the most important first decision we make is like, okay, whose patient is this really going to be relative to who's running the ship? Okay, is this going to be the dentist, playing like the general contractor and working with a bunch of subs, or is this going to be the chiropractor? Somebody really needs to kind of have the overall vision, and that's who that winds up being. And a lot of times that's me, a lot of times that's him, a lot of times it's somebody else on our team. Like I said, we've got this one patient that's got like 6 people working for her, and it's like, who's on first? It can get confusing, but you need to understand how all these different disciplines interrelate, and how they're working in a way that says, okay, well, if we've got 6 different people involved with this patient, who goes first, who goes second, and where do they stop before they pass on to the next one, and that kind of stuff. And that can get pretty complicated sometimes. Okay.
Part of that, too, is listening to the patient, that some of the real sensitive ones, they'll want to work with somebody. It's like, okay. And we don't fight with it because as long as they're all within the same network and the same paradigms, it's like whatever makes the patient feel the most comfortable psychologically makes it easier for the rest of us when it comes back around. Because we have so many patients coming from so many different referrals, it's like, it doesn't really matter at this point. We're not really struggling even looking for patients anymore. So it's become a very autonomous kind of group that sometimes the patient picks his own path, and I have them there. Do I need to go back to the dentist? What is this applying to? You're doing everything for me. I don't need to, and it's the same in reverse, but there's no, the patient doesn't dictate treatment because everybody's reinforcing the model back in through the paradigm.
With the exception of the fact that finances frequently dictates
That's the other part of it.
the saying. And so, this is something we deal with all the time. Ideally, for the developing child, I would like every case to work, to have the involvement of an oral myologist, okay, and the dentist orthodontist. And for the dentist or orthodontist to be treating an orthodontic case in a developing child, okay, if you've got the muscles working for you, you can literally sit back and just coast downhill. It is amazingly easy. Okay? If you have the muscles working against you, it's like pushing the bowling ball uphill. And so the difficulty becomes you send them off to the oral myologist, they get an evaluation there, and they get an evaluation there. We communicate. We've got a kind of a co-treatment plan, and the patient says, "Well, I can't afford both of you." And so we go, "Okay, well, let's see how we're going to make this work." So sometimes that tends to be like the biggest challenge we have. How are we going to manage that? And then the other part of it too is sometimes, and in fact more often than not, these things aren't all evident at the beginning. Okay, the working with Jorge especially has taught me this. They have this little order to their insanity within the osteopathic community to which they call peeling the onion. It's one layer at a time. It's like the most obvious issue the patient has. You deal with that, and that gets out of the way and lets other things rise to the surface. And when they rise to the surface, now we got to figure out how we're going to deal with that. And a lot of times, patient comes in and they've got a specific complaint, and I determined that the jaw and airway are a major issue for them, so we'll start with a nighttime orthotic, which helps them to sleep better, and that makes them, if you sleep better, you always feel better. So that helps them get kind of turn things around a little bit. And then they start progressing through treatment and they're starting to upright, things like that. Okay, we haven't got anybody else involved yet. And they come back and they're like half uprighted. And then they come back the next time and they're half upright and you're going, okay, that's it. Okay, we've obviously hit a wall. Okay, they're going to correct only so far on their own. Now we got to dial his number. Okay, something else. But I've learned that what you have to do is, as part of your original diagnosis and treatment plan, you have to make sure you include this team concept in preparing the patient. It says, okay, well, here's what I'm going to do for you. I've never treated you before, so I don't know how you're going to respond, because you may just, once you start sleeping better and we get this posture upright a little bit, you may just fly all on your own, and that may be all you'll need. But my experience is that those people are few and far between. Always something else comes to the surface. It may be emotional, it may be physical, structural, it may be past history traumas, whatever they are. But as they come to the surface, now we'll have to deal with them. So you have to prepare them in advance, because you don't want to you don't want to come and hit that wall and then seem like you're making excuses why your treatment's not working. Okay? So if you've prepared your patient ahead of time for that, you don't eat crow so much. Nobody likes doing that. Okay, so this is Richard's favorite part. I knew I was going to get him laughing before we start. Okay, so this is what so this is what Richard needs. This is what the chiropractor needs. Okay, unfortunately, his needs are relatively minimal, but they do require a place where he can actually treat patients if you're going to have them treated in your office. So that's I mean, he does a lot of treatment in my dental chairs, but there's no doubt about it, he'd rather have a table like this to work with than a dental chair.
Yeah, I don't do the blocking in the chairs.
Right, he can't do blocking or something like that in a dental
So I
chair.
can do assessment on the clients, or I can follow up after I've done the SOT stuff on the table, but I don't do the actual blocking.
So typically when he comes to my office, he walks in with one of these little overnight bags that he's got, a few trochanter belts and gloves. I don't know if you bring gloves or not, because
No,
because we have gloves,
Yeah.
and so he doesn't do that. So he's got his orthotics and he's got his belts and his blocks. Actually, I think you just leave blocks in the office. Right?
Yeah.
Yeah. So some of the stuff we just set the room up and they're already there. Okay. So that's what his needs are, and then this is what the dentist needs, and it's pretty. It's why everything is so damned expensive.
And this is for me, I put this slide in.
I know.
Because
That's why I knew he was going to laugh, because this was his slide. This is what he put in.
My perspective is that nobody understands, chiropractors, you don't understand how much more complicated, how much more expensive, how much more money they spend on employees than a chiropractic office ever does. I mean, it's 3 times, 4 times. So why does the dentist charge so much?
It's the cost of turning the room. I mean, you just pull a sheet of paper off and that's it.
I know.
But that's the thing, is that when I talked to a patient, I said, and you know what, I don't care what dentist I sent you, this is gonna cost a lot more than what I'm gonna cost. So I end up being, looking good because I'm the cheap part of the equation. So for the
And the dramatic part.
but that's the good thing, is you're selling the model, and then you're the good guy because you're not going to spend all our money. The dentist is. But it's a good thing to know as a chiropractor, but because you need to be positive about the fact that the dentists do need to charge that, because they have overheads that are unmatched by any other medical professional. They've got the highest overhead of anybody in healthcare, because they're operatories, they have all the OSHA stuff, and then they got the staff to be trained to do it, so they're doing surgery as well as they're doing holistic healthcare. So they're covering the full gamut: drugs, injections, all the liabilities and all the malpractice for that, plus they're trying to match what we do.
Let me pull my tie a little tighter.
And people ask us, like, oh, no, be the chiropractor. You don't want to be the dentist model. Send your kids to school, go to chiropractic school, don't go to dental school.
Do you have a question?
Well, just a brief explanation on the foot orthotics, what you would do in that regard.
Are we going to get to that in the slides later?
No. Yeah.
Why don't we just take that at the end, though?
Okay.
Because
Yeah, okay. Make sure to bring that up. Okay, obviously, I don't know if ridiculous is the word, but it's up there. Okay.
From our perspective, it's ridiculous.
Yeah, right.
Oh, yeah, from our side.
Okay, so there are some disadvantages to this paradigm, and one, of course, is that you know, he becomes the traveling show, and for me, you know, that's you know, he's, I don't know, 10 or 15 minutes from his other office, but if he's traveling all the way to Redlands, that's an hour away. He's going to Thousand Oaks, that's an hour away. So he can put on some miles in the car, and I don't have to go anywhere. I get to sit where I am. Okay, and of course that leaves him unavailable at his regular office at the same time, which. If he's in an office like he is, where there's multiple chiropractors, that's probably not an issue, not much of an issue. But he needs to obviously carry his own forms and all that stuff, and patients have to deal with those. And then we don't do his billing and collecting for him. That's still all really done through his office, and so pretty much he works like on a cash basis when he comes. So patients just pay him, and they pay me for what I do, and they pay him for what he does. We just keep it completely separate. Okay, so. That's how we're making the model work. But so there are those little things, but those are, you know, relatively minor. Once you got those worked out, it's just a matter of paperwork. And my staff is all pretty familiar with his paperwork, and they help out. And so I pay my staff to help him. It works really well.
That's the important part.
Okay, all right. For me, there's some disadvantages, and you know, and I'd say probably staff, you know, is the major hurdle there. And it's not that they're, you know, being obstinate or anything. It's just that you need to be really creative on scheduling, because we don't know exactly how long he's going to take, and we don't know exactly how long I'm going to take to get an orthotic delivered and or adjusted. Sometimes it's open your mouth, stick it in there, bite down, see ya. You know, okay, go over see Dr. Gerardo. Okay? And other times it takes us a half hour because they just don't quite fit right, and we want to get them all balanced out. So that makes scheduling, you know, very, very tentative, and you have to be really creative, and you have to have a staff that's very, very willing to be creative and adaptive, because pretty much your days when you have in-house, you know, therapists working with you, when Jorge's there, when this past Tuesday, Derek, Jorge, Richard, and I were all there. And it's like Chinese fire drill. I mean, it's just like total insanity. And so you have to be really flexible. You got to teach your staff to be really flexible and say, hey, just roll with the flow. And last but not least, you're going to have, you need to have that facility for your chiropractor, osteopath, craniosacral therapist, whoever's going to come in and work with you. And that room is pretty much like just dead space when they're not there. So if we're not using them a lot, you know, you're paying rent on an 8x10 or 10x10 operatory that could be used by a hygienist or something else. So you have to look at, you know, from a financial standpoint, that there's a loss of income when that room's not being used. Okay.
Being the fact I've been in many offices, sometimes they'll just move the table, and I'll use one of the existing rooms, like the hygiene room. They'll move over if it's big enough, or they'll take the table out. So you don't have to have a room, but it is definitely better for us if you have a room that's separate. But I've had more of the offices don't make a separate room. They don't have space, but they just figure out that either they put me in the kitchen, take the kitchen table out, and I'm in the kitchen for the day, or if they have an extra large room, a corner room or something, they'll take that table and either move it out, or they'll put it in the corner of the room. So there's different ways of doing it. His way was planned when he moved into the Montrose office. We've been talking already for a year or more. That's what he wanted to do, so he set it up, and we kind of worked out space-wise, so it worked out well. It's not a perfect room, but it's a good room.
Mm-hmm. Yeah, that was one of the things 5 years ago when we realized that a move was pretty imminent for us. It's okay, well, might as well try and build something that's going to work, and so we got started on that, and so we decided, okay, well, let's just move. So we started with a new building, and of course, no building is really set up to work the way you want, so we went in and just demolished the whole thing, gutted it, and started all over. And of course, this building, actually what was interesting is this is a building that was a chiropractor's office in the past. And the unfortunate thing about chiropractors is they don't, I don't know if they wash their hands or not, but they have no plumbing. Okay, and so you wind up having to do a lot of floor dissections and to get all the plumbing stuff we need in, and then of course you bring in the inspector to make sure everything is done right. And
he's inspecting.
Yeah, he's a good old dog. Okay, and then you involve your kids, you get them involved, and make sure they brought all their tools along so they can help you build things, and your spouse, and and you involve your other kids, put everybody to work, and you don't forget your staff. You get them busy too, and it becomes a real extended family kind of project. And then you make sure you include this, because this is what we've all been talking about. So we make sure that we built a room for my wife does some therapy, and so this was really designed. It's called Liz's room for a reason, but Richard gets to use it. Jorge gets to use it, Brenda gets to use it, a lot of people do, and it gets shared around. And actually, after 5 years, it still pretty much looks like that. It's holding up pretty well, okay, despite all the abuse they put it through. So then you try and be a little creative, and you do kind of, cool little colors, and then you pull in some really high-priced decorators to come in and do the decorating for you. And there they are with one of our good friends. And I find there's no place like home when you're looking for the best people around. And then we invite some friends to co-treat with. And actually, the two in the center, we've really never wound up co-treating too much. These were these two young ladies that run one of the local X-ray labs. And basically got down to where there was two labs that were close and convenient for my patients. And one of them had an ICAT, and it wasn't theirs. And so we don't see these two people very much, but it's the way things go. Okay. And then sometimes we do group things when Derek comes to town. It sometimes tends to kind of draw a crowd, and the look on Dr. Barrios' face there is pretty typical of what most of us look like when we're watching Derek. I think Richard's favorite saying when Derek is with us is he'll look at me and he goes, "Where did that come from?" Okay, because he comes up with stuff that we've just never seen or heard before, more often than not. Then we get to do this. Then we get to go to work and figure out how to pay for all the stuff that we've done. And indeed, there is a price to pay for this, and one of those is that obviously we need to pay for it, but at the same time, I think all of us that are doing this, I know Rebecca knows this very clearly, is that this is not your orthodontist office where the orthodontist almost never even touches the patient, just walks back and forth and says, "Okay, bend that wire, put this one in, change that wire." This is absolutely hands-on, 100% on every single patient. I adjust every orthodontic appliance myself, and probably 98% of those are the ALF. And I find the longer I practice the orthodontic part of my practice, the less I use brackets. And
well, I touch every patient. I just don't do cranial rhythm.
Well, yeah, likewise. Yeah, me neither. So, so let's take a look at what things we can do in the future. And I think first and foremost thing that we do is that as doctors, we have to do what we've been doing for the last 30 some odd years for me, and that is we continue to grow. I'm a totally different dentist than I was a year ago. And a year from now, I don't know if it'll be totally different, but I'll probably be a little bit different. We're still, pretty much in the same paradigm I was, a year ago or 2 years ago, but we're constantly using new modalities. In the last year or so, we've added cold laser therapy to the armamentarium we have for treating particular conditions, and so we're taking advantage of new technologies. We're actually sometimes now and then you find out the things that didn't help us in the past for whatever reason. You can go back and pick up some old technologies that turn out to be useful. Okay. But as we find becomes easier and more predictable to treat, the patient's chief complaint, those get resolved. Sometimes they get resolved so quickly that, the patient, after a few months, is complaining about this little thing like it's the whole thing. And I go, okay, well, let's back up and kind of review because I want to make sure where we're at. So I kind of go down the complaint list. And they've kind of forgotten about all those things. They get feeling so much better. They forget about all the aches and pains they came in with, and they're feeling so much better that some of the little things that weren't even anywhere near the surface now are up on the surface. And so it becomes a task for us to get more and more oriented towards the little things, which we never dealt with before, because it took a lot of effort for us just to get past all the big ones. Okay. And I say, number 2 up here is one that, of course, the study group helps me a lot with this, because I'd say a good 50% of the growth of the study group has been through word of mouth of other people in the study group. Okay? I get emails back all the time from members of the study group says, is it okay if I bring my friend so-and-so? And of course I tell them, sure. I said, the requirements for the study group is that you have a willingness to share and a willingness to learn. That's it. I don't care what your degree is. Okay? And we get some pretty interesting people rolling through. And some of them come because they think this may be a great way to get more referrals, and they don't get a whole bunch of referrals on the first visit. They never come back. And others stick it out for a while, and the rewards in that department get greater and greater the longer you stick with it. And I think that goes for all of us. Today we get a lot more referrals per month from the study group than we did 5 years ago when we were doing this. And that's because the study group has gotten larger, and our abilities have gotten better, and the word gets around, and that just helps all of us. Okay, mostly the patient. Okay, so pretty much, here's the team that we have that we're working with right now in terms of when we deal with a patient that has problems. And obviously the chiropractor, the SOT chiropractor, and myself, or again some other dentists, the osteopathic physician, and that's been kind of an interesting dynamic, because Dr. Moreno is someone that I met through Dr. Nordstrom. And at this point now, he's in my office for a full day once a month. And he at one time practiced out in Santa Monica with some groups out there. And I don't know if you know the routine, because it was talked about a little bit this week, but every 3 months when Dr. Nordstrom comes to Southern California from Hollister, basically he comes down, he spends all day Friday and Saturday working with osteopaths out in an office in Santa Monica, and then takes Sunday off. On Monday he's back at a different office in Santa Monica working with a different group of osteopaths, and they're doing basically this co-treatment. And then Monday night he comes to my house, spends the night, and then we go to the office Tuesday morning with the intent of treating Dr. Moreno's family. And that's how this all started. He invited me to Dr. Moreno's house to watch what he was doing with Dr. Moreno and his kids. And in this little room behind Dr. Moreno's garage, they had a table like this, and he just throw the kids up there, and he basically unloads his whole dental office out of his car, and he just goes to work on them. And so I invited him to come do that in my office, which I thought would be a lot more convenient for him. And I don't know, that's probably 7 or 8 years ago now, because that was well back into the Eagle Rock days. And so we've been doing that ever since. And Derek, I think, as you kind of caught from watching last couple, is a very, very giving person. And so the next thing you know, he's seeing some of my patients, and he's seeing some of Jorge's patients, and then he's seeing some of his own patients. And this thing is growing, and it's like a rat race to get him out of there, because he's got to be back in Hollister Tuesday night in time to unload all of his equipment, get it all in the sterilizer, get it all ready to go, because the next morning, frequently his schedule is such that he's in Santa Cruz on Wednesday doing the same thing with an osteopath there. So he's an Energizer bunny, and more often than not, when he comes to my house, it's 1, 2 in the morning before we finally give up going over cases and stuff. So I know Monday night's not a real good sleeping night for him. So it's a good thing he gets the day off on Sunday, and I'm hoping he sleeps a little bit. But I know he comes to my house Monday nights hungry, because you never see him eat. But I'm going to tell you, no matter how much food I put on the table, the plates are empty when he's done. We'll sit there talking about cases, and he'll just keep eating. Anyway, craniosacral therapists, there's quite a few of them in the group, and there's a lot of them around, and we work with them a lot. The next one, environmental medicine specialist, is
the craniosacral therapist, I think, has ended up being the biggest referral into the network. There are well over 100 patients from craniosacral therapy.
Yeah.
Well over 100 patients referred. Yeah. I don't see all of them. He does, but I still get some of the second ones that don't get resolved. They still end up coming my way. Ones that are not resolved.
So is that like a physical therapist?
No, craniosacral therapist is Upledger's organization, and craniosacral therapists are massage therapists. Dentists can go to get craniosacral therapy certificate through Upledger. She was formerly a teacher at Waldorf School. Waldorf has been like constant phone call. It's every month or something. There's one or two more. But
Okay.
the craniosacral therapist is Brenda. She was formerly a teacher, and she went and got I think got massage certification, and then craniosacral therapy. So she does a lot of work with.
Liz is shaking her head no, so,
Okay, Liz went.
You don't have to be a massage therapist with Upledger. You can just get your cranial certification from them without having any.
Well,
What
I
is
think it used
Upledger?
to be.
Yeah,
It used to be.
it's changed.
Okay.
Upledger Institute is in, I think, Miami,
Florida.
Florida, is that right?
Yeah.
And,
That's what I was-
but they do seminars all over the country, and they're usually
Well, all over
like
the world. They're the biggest cranial organization.
weekend to 4-day
Right.
seminars, and they have different levels, craniosacral 1, 2, and then they do visceral manipulation. What else do they do?
Yeah.
They
They
do
do.
limb,
Yeah.
they do heart-centered therapy.
Emotional
They-
work.
Mhm.
Yeah.
Part of their cranial sacral curriculum, their third one, is the emotional work.
Yeah.
So the first two is really the rhythm and the adjustments through the mouth, but the third one is all the emotional stuff.
And
Yeah.
Upledger himself is an osteopath. So he's kind of sharing kind of one level of osteopathic cranial work with anyone who's interested, basically.
So is this a licensed professional?
Yes, that's recognized. But it's actually a lay person, not actually a previously. It used to be they wanted to have some sort of healthcare degree, and then they broke that down, and anybody could take the class. And
It's a certification.
certification.
I
It's a
wonder if the
certification.
state would allow dentists to do that, even though you're
Yes,
certificate.
but you
Well,
still have
we're
a scope of
Illinois,
practice.
remember, we're not.
But
Yeah.
I don't know if they allow you to mix them. You could still have a certificate, but you have to check whether it's okay. But that's basically what Derek's doing. And the thing I brought that up is because you don't know where she ended up being the biggest referral in the practice for a long time. And she's been one of the people, several of them have been, they come back to the study group all the time because they're trying to understand more, because they're coming from a more lay person's point of view. They don't get the whole model, but they get the feel and they have the understanding of it. So it's not a bad part of the network to have. I mean, it's in there because they contribute. They do have an effect on patients. And Liz is also a craniosacral therapist, so she's treats patients also. But it's just that on a business-wise, it wasn't a bad thing to have them involved. And at first, it was like they were actually very opposed to chiropractic and the SOT kind of that model. And being around, they finally kind of lightened up. It's like, okay, it does work. So if you don't like the way I work, but it's like, okay, because the whole thing with osteopaths and the craniosacral therapy is that it's like you're not supposed to use more than 5 ounces of pressure, so it's a passive manipulation. There's never anything very challenging to the patient. They just kind of decompress, unwind, unravel, emotionally back down, whatever they're doing. Where we're much more, or the way I teach is much more direct oriented, much more physical.
Yeah, direct.
Huh?
Direct is a good word.
Active,
Yeah.
direct. Go this way.
Well, the orientation with a craniosacral therapist is much more about manipulating dural membranes than it is about
Structure.
physical structure. Okay, that is a physical structure, but we should say musculoskeletal is more chiropractic, dural is more craniosacral. Okay, in orientation, so it takes very, very little, very subtle, amount of pressure change to elicit a change in that dural membrane. But that's where their focus is. But nonetheless, a great part of the team, because they fall into the paradigm very quickly, understand. They're a great referral source because there's quite a few of them around. And and here's another bonus with the study group is that generally craniosacral therapists, like as a group, like not happy with the direct approach of a chiropractor, and osteopaths kind of in the same way. And one of the things that has been really kind of fun to watch and see is how Richard and Jorge, have grown in certain ways, because here's an osteopath and chiropractor that are almost kind of, polar opposites that now share patients, share therapies, they treat each other, all that kind of stuff, because, in the long run, we understand that it's not about us and it's not about what we do, it's about the patient, and we have to really keep that in mind. And boy, sometimes I feel like, okay, I'm going to go downstairs and get the boxing gloves for these guys so they can get it over with, and then we can get on with what we really want to do, because you can kind of tell there's some tension and friction, in various factions in the study group. But that's been one of my goals from the very beginning of this is to make sure we focus on what we're really there for. And it's not, about, oh, you do this and we don't like that. It's about what does the patient need, and do you have that skill? And come on, we need you. Yeah, we need you on this team, and we need you without bias, without prejudice, all that kind of stuff. We need what you bring to the table for us. Okay, we try to make sure we've got. So, so this environmental medicine specialist, this is kind of a rarity, I guess, because there's only one in LA that I know of, and that's Kathy Lippman, the one we work with, and she's in Beverly Hills, and so that creates a dynamic that's tough for us because I'm in Montrose, which is on the other side of the hill, and Beverly Hills is quite a ways away from us and for our patients. But environmental medicine physician, basically what she is an MD that specializes in environmental medicine. Basically what she is, she's kind of a holistic allergist. Okay, anything and everything in your environment that may influence you, whether it was like what a lot of us have been experiencing in the last couple of days with all the smoke in these casinos. Boy, I got nailed big time yesterday. I was feeling about as green as I felt in a long time, and I assume that's what it was. But she has some interesting technology that she uses that, like, no matter what it is, whether it's dietary, whether it's in the air that you're breathing, what it is, if it's bothering you, it's coming from your environment, she finds it. So she is a really, really good resource because, we're trying to teach kids, to keep their lips closed and breathe through their nose. And if they're like this, they're not going to, you can't put an appliance in their mouth and tape their lips shut if they can't breathe through their nose. And so a lot of times, you got to use that resource. Okay, so you got to have somebody like that on your team, and I don't know if there's actually a school for environmental medicine or whatever, and that's something we probably need to talk to her about. Is that how do people in other areas, like where you guys are, how do you find somebody like that? And I honestly don't remember how we stumbled on Kathy, but
she was referred in. So
yeah, but she's been a great addition to the study group.
What's her name, please?
Lippman, Lippman. She's in Beverly Hills. Okay. Yeah, I'll give you a link at the end here. That
she's got an internet website that you can find.
Right. Yeah. Almost everybody now has it. Okay. And then there's the oral myologist, and in the last year or two, we really kind of I don't know whether it's from me putting more emphasis on it or whether we just got more of them involved in the study group, or whatever. But these are the speech pathologists or the dental hygienists that have gone on to get certifications in oral myology, and these are the ones that you really want to work with if you're doing orthodontics. Okay, whether it's kids or adults, almost everybody has muscularly adapted to their distortion. And so when we as dentists or even chiropractors are trying to undo that distortion, okay, the muscles are going to want to pull it back. They always want to run back to where they've been. And this is why we have orthodontic relapse. Well, it's one of the reasons. One of the reasons that a lot of orthodontics is done that puts you in places you shouldn't be, and that's why it relapses. But even when you're putting things in the right place, the body just doesn't recognize. They've kind of forgotten that. And so these people can be very, very helpful on getting the muscles trained to get everybody rowing the boat in the same direction. And like I say, orthodontics becomes infinitely easier when you've got the muscles working with you instead of against you. And so they've been a great addition to the team. And the oral surgeons have kind of been there all along. And honestly, with the paradigm that we work in and do, we use the oral surgeon very, very little for facial reconstruction, mandibular advancement, that kind of thing. But we're using them for placing implants. They'll put orthodontic implants in for us if we need that, although I do those myself, and I think most orthodontists now have been trained to place orthodontic implants themselves. But they do provide an assortment of services. They can do the frenectomies, the more involved ones especially. So they certainly have a role there, and it's been kind of fun watching because they're like traditional physicians, they're traditional surgeons, and when we first got involved in the group, it was kind of fun watching them because I think the first night Fred came was the night that that you spoke, and Fred was sitting there kind of going like this, and then I think the next time he showed up was when Bob Wexler came with his headband thing. And Fred was just like, okay, this is like the dog and pony show. This is just total nonsense. But then next month he was back. So, and now, he's sending patients to Richard.
He's treating his wife for a low back problem.
Right.
And she told me that when he talks to his patients now, when they ask about it, he says, no, there's only one chiropractor I'd send you to if they're in his office because they've got oral or team treatment ready. He goes, this chiropractor over in Burbank.
Yeah.
So he's actually completely changed. I asked him one time in a meeting, he said, yeah, I've lost a couple orthodontists because I wouldn't pull the bicuspids because after seeing you guys for so long, I just knew that this was the wrong thing to do. It was so blatant. I had to call the orthodontist and say, you shouldn't pull these out. He said, then I lost them as referral bases. So it's really been hard. This is all sorts of talking to me at one of the meetings just last year, I think, or maybe early this year. But he said, but I couldn't pull the teeth out. It was just, there was no way that this was going to be okay. But this face was already wrong, and they were just going to ruin this person.
Yeah.
So I don't know what he's done with it, but I remember him telling me that, and he was just, you could just see the angst. He was just like, it's just,
Yeah.
I'm losing business for it, but I couldn't do it.
And that's the nature of this game. There's the pros and there's the cons, and there's one of them. That's a tough kind of decision thing to make. Is that how do you deal with that?
But
you
that's
have
part
to
of
make it. You have to make a stand.
But the thing is, it's part of this meeting though is the fact that it's something that people come to because every once in a while they have a good speaker, so they'll come in, they'll come a few times, but he's gotten slowly changed over time. That was 10 years ago when I first spoke, and he's kind of like, geez, these guys are fucking whack. The only reason he really came back is because Bruce had sent him so much wisdom teeth removal and implants and stuff that he was actually trying to keep a network that, because at first there was probably 6 or 8 dentists, a lot of them used him. So he came really for business purposes. He really didn't want to learn the model, but he'd sit there and listen. And so after a while, it kind of rubbed off on him. And he's not completely, stopped doing oral surgery, but at least now he looks at some of the faces and goes, "That's really not going to work for this case."
Yeah. It'll change you. It certainly does.
It'll change you, which is the cool part because he just can't coming back.
Okay, so what's beyond where we started, and obviously we're. Like I said, it's the little things that start floating to the surface now that we see. The emotional traumas, the past history traumas, birthing traumas, myofunctional disorders, lymphatic drainage issues, endocrine disorders, breathing disorders, snoring, sleep apnea amongst those. And this is one of the things that that I really like to emphasize with everyone. Okay, sleep apnea is not a disorder unto its own. Sleep apnea is just the nighttime version of a breathing disorder. Okay. People breathe bad 24/7. It's just that it kind of goes over the hill when they fall asleep because they lose all control of what's going on. Genetic disorders, and last but not least, and probably the most important one, and this is the one that's probably the most frustrating, is the iatrogenic disorders. And I'm sure you deal with this a lot. Is that how much of your practice is devoted to fixing somebody else's mess? Way too much. I can tell by the look on his face.
It's huge.
Right. It's way too much. Okay. And so.
The chiropractor understand.
I'd like to say something about the equilibrationists.
I knew this was coming up.
I had a case recently, and this poor woman went to a local dentist for TMJ treatment, and he just systematically removed all the supporting cusps down into dentin on all of her teeth.
Oh, come on.
Oh, no, it was like floating teeth on a horse when they just going, she just was missing all of her cusps. So I sent her to peer review. And then I didn't bother to really look and see who the dentist was. I thought, who is this ass? I didn't care. And then as it got closer to her date with peer review, I thought, who is this guy anyway? Well, past president of the dental board in Arizona there in Phoenix. He was on the peer review committee. He was independent examiner for them. He had all these accolades, and I'm like, uh-oh. Needless to say, they found in his favor that there was nothing wrong with the treatment he provided.
Well,
It was standard of care.
It was within the
for
standard of care.
TMJ.
Yeah.
But I mean, he even left burr marks in the dent, and that's how I knew she didn't grind them down herself, because then it's
Right.
polished and it's
Yeah.
glassy. But
Sure.
yeah, he left like deep scratches in the dent. It's terrible. She's in treatment with me now. I've had to rebuild all the cusps so I can even get somewhere.
She
with
has something
it,
to work
you know?
with, right?
And for the chiropractors, this is a big point, that understanding that these guys are all bucking the mainstream of dentistry, and it's always they're always in a liability position, because if the patient doesn't like the result, the dental board's going to say, you're not standards of care, you're going to pay, or it ends up being a malpractice. So they're vulnerable, where we're not really. I mean, there's no liability for us, because we're still doing chiropractic and doing cranial work, and we're not really there's no real threat of being outside of scope of practice at all, but they're pushing the boundaries of what is normal dentistry. And so it's just a perspective you need to understand about the dentist, that they're really stepping out on the edge and trying to really be more of a healing profession, and they want the rest of the profession wants to punish them for that. They don't like them doing it. It's a threat.
So I have a question. If we're in a, I've had several lunches with dentists where they kind of look at me like I'm smoking.
You tell them that's later.
But if we're not in the fortunate situation to have a marriage of philosophy like this, how do you talk to a dentist who isn't on the same page with you?
You can't sell them if they're not already sold.
Right.
And the biggest thing why I continue to do this is like, look, if they're interested, it's like, look, come with me to the next one, because they've got to see the whole model or they'll never change. But most of them have already seen parts. Like when I first met Bruce, it was like, you're one of those guys, because he'd seen the presentations from different people that, there's these chiropractors that move the bones around, and that you can actually change the bite pattern, and it's really important in the TMJ. So he was already looking at it without knowing what he was really looking for, that it was, how to do it. So this is really about bridging the gap to make it easy for you guys to do that with them, because all you do is looking for somebody who's already interested in it, even though they haven't found their way through it yet.
But are you you're at a place where you're just at the point like, I don't even know where to start, right?
Yeah, it's kind of just me right now.
Yeah.
Right. What you need to do is start calling the dentist and just go, do you do TMJ therapy? You can ask them what philosophy they follow, and then call some of these other guys and go, what the hell is this? Sort of stuff, if you want. But and you can ask, do they believe in chiropractic? Do they believe in holistic? Take them out to lunch, and whatever. That's how you're going to find these people. That's what we're doing with chiropractors. We're calling, because believe me, guys, you got your number of colleagues that are a bit questionable too.
Absolutely. I started looking for dentists in 1994 or 5.
It's hard.
And I didn't get really hooked up with Bruce until 1999.
That's
which really got me to everything I've gone through.
Right.
Because you have to have the first guy, because he actually took me to the CDA meeting. We went to, that's where I met Olmos.
Mm-hmm.
We did, what else did we do?
Oh, we went to AFO.
AFO.
We went
So
to
he took me
chirodontics. We went through chirodontics together.
We did chirodontics. So he had 3 different things that we did
Yeah, I mean,
that were very important, but that's what the network was.
Midwest.
So the whole thing was that when I called him, he was like, oh yeah, you were one of those. So I went and had lunch with him. I'd already gone through 2 orthodontists in West LA and another general dentist. The general dentist was like, oh, you're way over my head. I know, I don't do that stuff. And the orthodontist, oh yeah, just said, no, 3 orthodontists. Send me patients, and then they never would respond. They never changed. They just wanted me to send them patients. So I sent them 1 or 2 patients and went, all right, enough of that nonsense. But it took me 5 years of really, I didn't go actively call everybody, but every time I had a patient that had TMJ, who's your dentist? Who's your dentist? And then I'd call them. And that's how I actually I got sent to a dentist who was supposedly did some TMJ work, which my ex-wife went to, and I went and talked to him so I was still married with her, the ex-wife. And I had lunch with him. He was like, yeah, I do TMJ. And I started talking about the cranial work. And I said, oh, yeah, that's it. You're way over my head. He did TMJ, but on a very, nighttime display, for grinding stuff.
Yeah.
Nothing functional, really. So he gave me Bruce's name.
The irony is that I had just met him like the weekend or so before.
No, it was like a year before.
Well, it may have been that long.
Yeah, no, it was a year before. So I remember going, you were at that meeting.
Yeah, we were at a meeting together, sitting in a class, and we turned to introduce ourselves, and he was from Glendale and I was from Eagle Rock, so we're neighbors. And so we got talking a little bit, and obviously he was kind of a newcomer to the whole thing, Okay, and I'd been doing this for quite a while, and so that's how he wound up passing my name off to Richard
And,
when
and the other
Richard
part
saw
was
him.
that the dentists love to go to meetings. Chiropractors don't. You want to meet guys, go to meetings. Find out what the dental association meetings are, figure out who's doing what. Because he was at meetings before that I met him at, that some other dentist had put on that was doing functional orthodontic stuff, and Dr. Budding, who's a long-time SOT craniopath, who'd been working with dentists before, had been messing around with the dentists. So he actually took me to that meeting because he knew I was interested in it.
You know, the other thing you can do is check the directories.
Yeah.
Livia Lemke just started one for ALF practitioners. It's alforthodontics.com. The Cranial Academy has a directory.
Well,
This organization has a directory.
the AACP
Yeah, the AACP
is a
has
good one
Yeah.
because
That's kind of a crapshoot, though.
Yeah, no, it's
Oh, yeah.
well,
totally.
there's all
Yeah.
different philosophies in
Yeah.
there. You kind of have to respect different philosophies, but at least it gives you a starting point.
Yeah.
Right.
Yeah.
Contact
You
somebody.
don't want to get somebody that dabbles in TMD.
Yeah.
What's
Because then you both look down.
The
Never get out of
American
the
Academy of Craniofacial Pain.
Okay.
I think it's aacfp.org.
No, I think it's just, they don't.
Yeah, it's AACP
no
now.
F.
.org.
aacp.org.
The IAO is
Where do you
probably
practice?
another source.
Well, that's even a broader.
Yeah, it is, but it's still,
It's another.
it's better than
Their
just
dentist
going through the phone
runs
book.
NFL. That's not no man's land.
I like to actually. We're in the kind of the same area, and I'm not an expert, obviously. I mean, we've never really met, but I do some cranial now. What I've done, and Charles helped me on his website. He has why dentists and chiropractors should treat together. So I hand that to the dentist. But what I do is I've talked to my patients about their dentist or get their numbers, and then I talk to the dentist and say, do you have any patients who you start treating their mouth and they start having back pain? And that's my way in usually. And I actually had a meeting with the woman on a Monday, and by Wednesday I'd already had 2 referrals. And that's how I've got it. But I'm not doing your model yet.
But the thing is that you're absolutely that has the awareness, but the understanding that there's something else, even though she doesn't do it. And it's like, great, I can dump these patients
She
off.
had no clue, right.
I can get rid of these patients.
She gave me her mess.
Right.
She gave me her
Right.
But you know, but
That's
once
what
you
they're gonna give you.
straighten it out, then
But they understand the
Then
first
the first
referrals
one.
you're going to get from any of them are going to be the worst ones. And
I
you're going
know.
to think, why am I doing this? For the first couple years, I'm like, why did I? What? Do I really want to continue doing this? The psychological primary, the ones that have had multiple therapies, and there's so many confusing things going on because they've had so many different people's hands on them that they're just a mess.
I
I mean,
haven't
the first
gotten
ones from him were the mess. The first ones from Shirazi were horrible. The first ones from Tavasian were horrible. Dermasian didn't send. He didn't want to send them. He sent them to somebody else. But he's the ones that didn't get fixed from the other guys. What I got, and I was like, every one of those, you work twice as hard. Now they're all gotten easier because I don't
Sure.
just get the hard ones. I
So
get
you
all of them.
proved yourself.
Yeah.
What I'm saying for them is that trust me, you're gonna have to, there's no free lunch here. You're gonna have to work your way through it.
Absolutely.
that's the door in. See,
Right,
I'm
yeah.
doing it. I'm seeing the other thing. We're
Yeah.
trying to court the chiropractors, and what are we getting?
That's what
the
you get.
ones that don't
But
get
that's what-
better.
I understand. But that's exactly what. Right. That's how this model's going to start. It
Right.
doesn't start the other way.
Right.
Because
That was my point.
you're not going to just send a patient because it makes it easier. Oh, I can take care of this and fine. My ego says, I'm not going to explain that. I don't understand it. So here, we're going to do this. But you, go see them because I don't know what to do this.
Right.
Get out of here. Just make my
But
life easier.
it comes from both sides.
Because
Right.
does go both ways exactly that way.
You know, it is exactly. It was that way for the first 2 or 3 years. We didn't start getting easy cases.
No.
I mean, what I sent him and what he sent me were like, because we didn't even know what we were referring yet at that point. We just knew this is a mess.
Right.
I don't like a patient,
And then
or they're
once you
not a
start
easy
sorting
patient.
it
Yeah.
out,
Right, it's easier.
Yeah.
You're like,
it settles
a new
down.
doc in town who
But
gets all
the big thing to understand is it gets easier because you get
Yes.
the worst cases
It does.
first and understand that. Every damn dentist I've gotten online, the first 2 or 3
Be
cases
nice.
I've gotten, crap. I was like, this is not fixable. Some of them are, but some of them aren't. I've had 1 or 2. I mean, it's like, oh man, at least send me any others because this one is just not working.
Poor Richard.
But they're gonna often have the same ones. It's not gonna be just me. That's gonna happen every time the same one because as you start a relationship, they don't know what you do. They're not gonna send you anything but stuff that there's no risk to them. They've already lost it. It's already something they want to get rid of.
Yeah.
That's what you're gonna get. Period.
I got a patient that's totally broken down.
Yeah.
Yeah.
Yeah. Great. You can help me with that, or you can take them off my hands. Good. Go.
Some of them
That was
were really well taken
Yeah.
care of.
What's that?
A few visits. I've had a few of them that were a mess, and a few visits they were just horrible cat twos.
Yeah, right.
And you know, a few visits, and they loved me. But one of them owns a huge yoga studio in my town. I get referrals all
Yeah.
the time now. And it's been a
But
great
that's right.
thing.
That's how you create a reputation.
Yeah.
Yeah.
And that's what the whole thing on Thursday was, that it basically, if you just follow the fundamentals, you don't have to be the guru in cranial, because most of them are busted category 2s that aren't resolving. If you can settle that down, you look good. You may not be the greatest guy in town, but you look good. Unlike
Okay,
most other
we
chiropractors
got-
who don't do that.
We got 1 minute, so let's get done. Okay, so last one on here, and I realized with a smaller screen that as big as I tried to make all these, I realized that it's not very readable. But the last one says enhancing physical and mental health with adjunctive therapies that enhance physical fitness. And this is what I alluded to a little while ago, is that, you know, once you start peeling the layers off the onion, you get all these issues dealt with, they feel so much better. So now they feel like exercising. Now they feel like, you know, taking better care of themselves. They get more physically fit. And so the paradigm continues, and we continue to draw in some people that can help us with some of those things. And so here's some of the other people now that we're getting more involved in the study group and in our co-treatment model. And this is the acupuncturist, the naturopath, the exercise physiologist, Feldenkrais practitioner, hypnotherapist, lymph drainage specialist, biofeedback therapist, reflexologist, aromatherapist. All these people are, you know, basically represented in one way or another in our study group, and we find that they become very, very helpful in taking people that next little level. Okay? We thought our job was done, you know, once the jaw joint stops popping, but if we're really going to be doctors, then we want to make sure that we satisfy our patients' needs. And I'm not saying that I'm going to provide these therapies, but I'm going to provide the referrals. Okay? Well, and a lot of times the patients, you know, will ask, they say, well, you know, my back's not hurting anymore, but I still, you know, I've got this allergy thing that's driving me nuts. I said, okay, well, all right, where's Kathy's card? You know? In fact, one of the latest things I did is I bought one of these side-by-side little business card on the wall holders, and this thing's about that long, and we just got all the cards lined up out there, and I just march the patient out, and we just go down the row and pick out the cards they need, and that's been one of the best things I've done in the last couple of years, is put that card rack up. The hardest thing is getting all these people to keep me stocked with cards.
And that list becomes a huge referral network. It's like he was in yesterday with us. The chiropractor is an acupuncturist that she's in the group now, so she's now in the model because she melted down yesterday. And it's like she's been on the fringe of this thing, kind of referring patients, but not really fully engaged. And it's just once they get treated, it's the referral network, the business part becomes huge because now they really understand the meaning of it once they get treated. So treating these people is a really big thing that helps develop your, not cooperation, but the reinforcement by other practitioners that there's a place for this. And so I've treated a lot of the different people at different times. It doesn't mean they all love what I do, but they understand it and they know there's a place for it.
That's a little smaller.
This is getting pretty small. I can't even read this one, but this one was so long, I said, okay, well.
It should have been 3 slides.
Yeah, right. Well, I threw all this on there because, and basically we've talked about all this already, but what, you know, what I decided to do is just put one slide up here that walks us very quickly through the typical chain of events that we use in this model, and that's basically the patient, you know, arrives with some issue, and I'd say a vast majority of them are airway related, okay, and they're orofacial distortion patterns that adversely affect the airway. And so where we're going to go is with a nighttime appliance, daytime appliance, chiropractic adjustment to help their bodies start to remodel and reshape to that, and pass through those stages, and then eventually get them into phase 2 treatment. And along the way, it's all about dealing with, you know, the sleep issues they have, the GI problems they have, the neurologic issues, the cardiovascular issues, all those kinds of things that we deal with. Okay, and so, like I said, we've talked about pretty much all this already. Okay, and we talked about that, how to resolve them, and again, it's the same stuff. It's using the cards. Just a couple of cases that Richard and I or some others have been working on recently, and this is what happens. We get those that are they're already in therapy, they're already working with a local orthodontist, and they've got brackets on their teeth, and especially in developing child, I find that brackets are really contraindicated because they tend to lock up growth.
Understanding the dentistry was paramount. I sent this to, did I send this to you? You sent this to me, but I.
No, you referred, they were referred to you and you referred them to me.
Yeah,
Okay.
and they had braces on from a traditional orthodontist, and they're in the overachieving tennis program. They're fanatical weekend tennis player. I mean, competitors. The family is both this one and the younger daughter. And they came in because they had an Osgood Slaughter's problem, which I corrected. And I said the braces aren't going to work. And I showed them why the braces were creating problems, the weaknesses it created. And the mother didn't even hesitate. She was, well, you have someone else you have a consult with? I didn't like the orthodontist anyway because her explanation, I didn't like her explanation. And this is a very well-respected, affluent dentist in a very affluent area right down the street from him who doesn't like him.
For obvious reasons.
And they went in and had a consult, and 3 weeks later had all the braces pulled off. Because they were so much in the function, the performance of the kid. And I said, look, this is affecting it, and I was able to show them why and how it worked. And not talk about it, I actually showed them how it changed mechanics. And I couldn't believe it. But both kids were just got the braces pulled off. Both of them.
Both of them.
Both of them were in braces, and they both got pulled off. And I'm sure the orthodontist isn't going to give back all their money.
No.
No.
So, but it tells you what power this has when you have the model as just part of the way you talk. You're not selling it. You're just like educating them. Like, this is the way it works.
Right.
She went, yes, yes, yes. Came back to this guy. What's his name? I'm gonna go see him. And after the consult, came back and said, I think I'm gonna take the braces off. I said, that'd be a good idea. They did it. So the idea is that who sells you the best, yourself or somebody else? And my whole thing is this: that the other professionals are the best referral for you. That's what MDs have always done, and what we've never done. And the dentists end up being your best referral because you don't have to sell them. They come in, yeah, you're going to need 8 to 12 visits. You got to fix that category 2, and the dentist, will see you because you know how he works. And that patient goes, okay, that's what he said too. Yeah, all right. And as long as there's agreement in the professionals, the patients feel like you're being taken care of, and you don't have to sell chiropractic. You sell the model, which sells each other. Which
sell
means,
very much of it.
Yeah, it sells itself because it's all education.
Because it makes
which is
sense.
really a practice management kind of fundamental teaching.
Right. The interesting dynamic in this case is that the orthodontist kids are classmates of theirs.
Yeah, and that's how they got to their.
And so mom, well, how am I going to explain this? How am I going to do that? So, so my answer is always the same. I said, you must understand, this is about your daughter. This is not about the orthodontist. This is not about me. It's not about Dr. Gerardo. It's not about our needs. It's about her needs. And if you feel that we're going to fulfill her needs better than what she's been getting, then we need to make a change. And how you handle that is up to you.
And I find a lot
But
more
it's
mothers
not the first time.
receptive to this than I ever would have believed. They actually, if you can make sense of that up for them, they will jump ship. They want cosmetics for their kids, but most of them really want health. And that whole airway issue is a big deal. When they notice their kid isn't breathing as well, and that you can improve their breathing, or the dentist can improve their breathing, they're like, okay, I'll talk to him, because that means a lot to a lot of these mothers. There's a lot more awareness out there than you think. I mean, there's a lot of people that don't, but there's a lot of people that do, and they just want someone to give them information. And if you can, on the fly, while you're doing the chiropractic stuff, be able to talk about it and show it, that perks interest, and it sells itself.
I think the biggest part of that is that when you tell them that there is a relationship between what you're going to do dentally, orthodontically, to the rest of their well-being, whether it be, foot problems that young lady was having or whatever it may be, that makes some big.
Do you just have cases left? We're done with the lecture part.
Pretty much.
You took the one out with how we set up pay structure in Schroeder's office.
Yeah. Yeah. I thought, well, you said.
Okay. Huh?
You said you asked me to take all those things out.
No, I didn't.
Okay. Well,
anyway.
we'll touch on that. Let's finish these, and you.
Well, I say we're out of time, so I don't know. Do you guys want to watch cases?
Oh, I've just got
You
2 or
want-
3 slides.
Okay,
We'll just
all right, that's it.
because we don't need to elaborate on all these. 'Cause
Okay, then we-
this is just typical what we see, and of course the difficulty is that an orthodontist is going to see a case like this. So this is a piece of cake. some brackets and away you go. And this lady's done. And she's far from done. Obviously she's got his problem. This is the lady that Richard showed the other day. And what we didn't get much of a chance to see was the kind of dental relationship she had. And so once you can see why she had airway problems, sleep problems, and
She
of course
had braces too, didn't she?
Yeah,
Post-orthodontic, adolescent orthodontic. I mean,
I think so.
that's how they finished her.
I think so.
probably. I mean, that's typically how they do it. As I recall, I don't think she ever had been treated. I don't
Oh,
think she
no? I
was.
thought she was.
Okay, that doesn't matter. Okay, either way, you get them that way, with or
That
without.
way.
Okay. Okay. There's multiple, issues, and we find, that the ADD and ADHD and all of
Can you go back to the other slide?
Sure. Yeah.
You're right. When you look at that, how many orthodontists that you know are going to take a look at that patient and say, you know what, we need to bring her maxilla forward?
Wrong, none.
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 Well, there's a
You
couple I
chiropractors
know.
understand that, right? Yeah, at the end of this week, you guys understand that model, that the traditional orthodontists would bring that back, not bring the mandible forward?
Yeah. Forget this picture. Look at
Not
this.
even that, but I mean, look where her maxilla is right now.
Yeah.
My opinion is
Too far back.
that's too far back
Yeah.
already.
Yeah. Oh, right. Yeah.
Oh, yeah.
Yeah. When her mandible is in the right place, she's class 3.
Yeah.
Yeah, because her maxilla is retrusive. But those are the things you, as chiropractors, are going to learn to identify, and that's part of that slide we had about what the chiropractor needs to know. You need to know and understand, and that's one of the things that we teach a lot is that, class 2s in dental, and we talked about this the other day when we talked about dental terminology, class 2 is a retrusive position of the maxilla and a more retrusive position of the mandible. And so both need to come forward. It's just that you need to bring the mandible forward more than you need to bring the maxilla forward. So. Okay, anyway, obviously, they come with all kinds of issues, and so with young, old, otherwise, we deal with those. This lady did have orthodontia, and I don't have the pictures on here, but her 2 centrals, those things are missing about 1/3 of the vertical structure. She has just ground those 2 front teeth. That's why they're so dark, because the chronic trauma from her bruxing on those things, and just grounded the bejeebies out of them. But she's one here, and this is where we walk on thin ice a little bit. She comes in with a chiropractor. Okay, and after a few visits of working with me, things aren't going right. And so we sit down, we have a little chat, and I say, I'd like to work with new chiropractors. I like to expand the paradigm. I like communicating with them, see if we can get everybody on the same page. But if we can't, it's not about you and your other chiropractor. This is about you and your needs. And if they're not meeting your needs, then we need to make a change. And so I felt that was appropriate in this case. So I says, well, let's see. If he doesn't help you any better than your prior contract, you can always go back. Okay? So we can always backpedal if we need to. But she walked out of his, out of seeing him and says, okay, now I know I'm in the right place. Okay. She was infinitely better with one adjustment. And so it sells itself out. Okay. So we're not going to go through this because this has been covered before.
They also want to see the dental orthotics, so whatever we can skip here, that's...
Yep. Okay, well, basically this is just the steps we go through, and we've really touched on all these all the way along. Okay, and then this one last thing. Yesterday or the day before, Dr. Nordstrom always starts his thing about, I wish to perform miracles, and he's a Da Vinci fanatic. In fact, I think he made everybody stand up and say it after him. Okay, he does that like at almost all of his seminars. And so I'm going to finish mine in kind of a little different way. And this is another miracles kind of thing that I saw. And this one says, one person can have a profound effect on another. And two people can work miracles. They can change a whole town. They can change the world. And if that isn't more appropriate for co-treatment, and that is what we are all about. Okay, so thank you very much. That's it. Okay, now Richard had some things he wanted to say about
You asked about the
payment.
business model. I had a couple of slides that got taken out.
Hey, well, we were running over already. You had to cut
I know,
something somewhere, so I cut these slides off.
That's why I said start at 8:30. I've worked in 7 to 8 different offices, so I've had all kinds of variations. His is the most unstructured. So I
He's
basically
being nice.
I charge the patient
Politically
separately,
correct.
so I charge $75 for their regular business. I charge $150 for the initial, and they pay me directly. Most of the offices don't like doing that. Actually, most of the dentists want to get something. So the basic kind of price break or whatever, they usually collect about $25, and they'll book and schedule and collect money, and if they have insurance, I negotiate whether I'm going to bill insurance or not. I have one office, Dr. Feld, I think you know who Dr. Feld is. He wouldn't bill insurance at all. He just had everybody do care credit. We did it up front, and he paid me $60 a visit, and I got $140, I think, for the initial, and he collected all the money. I just billed him directly. But he had a big operation, 22 staff, so he had this whole thing network set up. Dr. Shirazi right now, they collect the money at the front desk, but it's paid to me directly, and I pay him back $25 per patient that I see per day, and $50 on a new patient. He has a separate room also. It's obviously much easier with a separate room, but the only two I have that's had separate rooms, the only two that are still existing is Bruce and Dr. Shirazi. I was the same at Tavasian's. He actually put me in his kitchen, so I was upstairs in the kitchen, so they couldn't have lunch today when I was there. But they paid me separately at his office also. So the idea is to depend on your space and your availability and your staff. If you're not going to do high volume, it's easier just to have paid directly to chiropractor and just leave it as a separate deal. It was Shirazi and Feld and even Tavasian. Tavasian, I got up to about 15 patients a day, twice a month. Feld, we were getting up to 15 to 23 or 4 every week for me, one day a week. And I had an assistant who would go on alternate weeks, so I had 2 and a half, so it's bouncing around it. Thousand Oaks, I have someone else alternating with me, so I go every other week. But we have someone there every week, and we run anywhere from 8 to 10 when I'm not there to as much as 22, 23 cases for me to see.
You charge a little bit. If you take more time with a patient, do you charge extra?
No, in the dental office, it's pretty much become $85. If they're taking a percentage, I've raised it to $85. If Bruce is in it, Boston's it was $75 because they're not taking part of it. But I still charge extra because I'm traveling. And if I stay in my office, it would be easier, better for me. So I call that a traveling fee. And I'm actually from what I've been asking around, I'm actually at 85. I'm not actually overcharging for what a lot of the guys that are doing the work I do charge. They're all charging between $80 and $95. The way I work those, I'm actually faster than most of them. Most of them, Mursky, Blum, Schoenfeld, Bloink, who else? They're all spending half an hour with the patient. I like you, but not that much. So I'm a little more get in and get out, and I try to keep it much more kind of a straight SOT protocol, meaning that I want to have it be run fairly quickly. I run really more like 20 minutes in the dental office, so it's a little slower. I only have one room. Sometimes it runs half an hour, but I try to get it. They pretty much schedule me 20 minutes in most of the dental offices. So that's basically the basics of the mechanics of it work. So if you're starting low volume, it's just easier just to let them take a half an hour to 40 minutes, depends on the office, but half an hour is what I basically do.
And then in the initial visit is when you, or in the report of findings, you kind of lay out a plan for the patient?
Well, if I'm in the dental office, all I'm doing, I have a standard kind of protocol that is understood by the dentist within a very short amount of time, is that phase treatment, you're doing TMJ, this phase 1, it's really pain, musculoskeletal. That's category 2. They're not having to diagnose here. If they're a category 3, they should already been in your office, meaning they had collapsed disc. Very rarely, I mean, maybe one a year, not even one a year. And I'm talking of doing 60, 80 new cases of TMJ a year. I don't think I have more than one a year that's actually a lumbar disc major. They're all pre-diagnosed. They're walking in, it's category 2. So it's like all I'm doing is proving to them what it is, the relationship, and it's okay, you're going to come in once a week or twice a week, depends already. And once a week was kind of the minimum I worked out. In the office I worked every other week. It's always been a lot tougher to complete the cases. Feld's office and Shirazi's office, and I worked in 2 offices for Feld. We were once a week, and the once a week stuff was flat out faster. And at Feld's office, you guys know Dr. Feld? He didn't do laser, he didn't do Enerjax, he just did the orthotic and said, here, for the first year. So I basically managed the cases. And we had an argument about a case, and I was right, and he was wrong the first time, and we had a real low flowers. And he got to that point, and he goes, okay. The staff was like, what do you want to do? I mean, the staff basically turned the cases over to me, not me and all of you, but one of the transition staff. Are you done? Okay, great. Next. And they'd come once a week, and we were 10 to 12 visits is what first phase treatment was to get them calmed down in most cases. There's always the more complicated cases, but that's not the majority of the cases. Majority of the cases, if the TMJ appliance is done correctly, you're looking at starting prolotherapy and finishing disc replacement or disc integrity somewhere in that 8 to 12 visit range. And if you're not, you're missing up because it's how fast it works. Now, if they're really difficult metabolic or complex sensitive type, that's usually double. But I'm just talking about generically, okay, how that works. Does that answer most of the business model question?
And just one more thing with insurance. So if you, for example, in the setup that you said you would go and just be paid like a flat fee, like there was nothing taken out, like if you would charge $75 if the dentist didn't take anything, like Dr. Johnson, like doesn't take any out fee. Now if the patient had chiropractic coverage with their insurance, would you be
Like a
billing?
deductible and then just bill insurance, yeah.
And you would do that in your own,
Yeah, that's
on your own?
currently Shirazi's. He's in a rural affluent area. Canale Valley is a very upscale area, so there's a lot of insurance.
Okay.
The other office, Feld, had no insurance. It was all blue collar, and it was really hardly anybody had insurance. So it actually was better the way he did it. For his area, he already knew that.
Okay.
In the area, in Canale Valley, we get at least 50% insurance, maybe 60% insurance.
Okay. So you just basically, you get their insurance info and then
Yeah.
your staff
And
takes
it's
care of
actually, in those offices, it's very important because people are like, I want my insurance to pay.
Yeah.
I mean, it's like more affluent areas, they have insurance, you gotta bill my insurance.
Mm-hmm.
The ones that don't have insurance, they just like care credit or whatever, they'll just pay. It's like, okay, it's gotta get fixed. So they're actually a bigger pain, the Shirazi's, than the other offices.
Mm-hmm.
And so we've had some struggles getting the dental staff to understand, to make sure that how to explain the insurance stuff and getting the information and tell them they got to pay for the first visit, or they got to pre-approve the insurance before,
Right.
or they're paying full. So money's really an issue with those people that have insurance. They want them. What's my insurance going to pay? And they only want to pay their co-payment if they can get away with it. Then they will really push them.
Because they're leveraged to the hill.
Yeah, they got the Mercedes out in the parking lot, or the Hummer. And
Three
they've got the the 5,000 square foot house, and so. All right, so all that's left now, we're done with that. So I told you guys I'd show the foot orthotics. So if you guys are good to go, then we'll mess around.
What company are you using? Is that the one?
No, this is Everflex, and I buy directly from them. Most people can't do that because I do the high volume. So if you want to use these, you can call me. I kind of have some distributorship, but I haven't really set up completely yet because I haven't had enough people that actually buy them from me to really have a whole deal. But I actually teach how to use them and why these are done posturally, not to create. I'm not doing podiatry. These are strictly to change the posture, support low back change, and improve the posture of the patient. If I'm not improving the posture of the patient, I don't want to use them. So I end up throwing out half the orthotics people are wearing because they're to support the system, not correct the system. If you're correcting the system and the TMJ, and we're correcting stuff craniosacrally and musculoskeletally, the foot posture needs to be corrected also, meaning that it's pushed in a direction of correction past where it already is. You're not going to just adjust it and expect it to go back. You want to change to make a permanent change. Well, why would you want the same change for the feet? And this really evolved in the last 3 years because the lecture showed you how the feet and the jaw stuff break down at the same time. But we have cases, and Dr. Olmos used to have them all the time too, that the neck wouldn't come back up. Well, why is it not coming back up? You fixed the jaw. Well, it's because it's an ascending postural profile all the way down from the feet. I had one case that the oral surgeon treated, did the clean out, lavage, and head posture didn't come up. The jaw was still stuck. What happened? I had been treating a patient off when I was a nightmare patient. She was a neuron with all kinds of emotional issues, and we couldn't clear anything. I was like, oh my God, this was like 5-7 years ago. I stuck foot orthotics in her, and literally she picked her head up and her jaw came loose. Only time it's ever done that, but so I knew to see one of those. It's like, okay, I can't ignore the feet. And the reason I use these is that these are kind of the carbon flex like you do with the bikes, is that it's a memory. They can bend it and it comes back. It's not the stiff, rich orthotic, but it is still a stiff orthotic. It's a resin. So when you step on it, it's this. It pushes back. So whatever the foot is, I'm correcting it up above what it already is to the level that it takes to improve the posture. With the understanding that you can't push them too far or they start having problems, which is why the podiatrists don't do it. Podiatrists go between 0 up to probably 4 degrees, and they don't do much with that. That one case I showed had 90 degrees. No one ever does that, because you got to manage the whole system. That kid ended up being able to run marathons and play football and the rest of it, because the rest of the mechanics have to be freed up and have to be balanced. You can't be trying to push that into the system's imbalance because they'll break down. I mean, 90 degrees, you should be rolling off and spraining your ankles. This kid never sprains his ankles. And that understood, there's a real learning curve to this. I put him in 4 degrees, I think, and he calls me and goes, could those things make my back spasm? I said, what do you mean? He goes, well, I put him in like the week before and I came back. No, you called me. I put him in, I split, and you called me 2 days later and said, my back spot locked up. And I said, go take him out. So I saw him the next week, I adjusted him, I maybe adjusted again, put him back in. He hadn't had any problem since because he had some category 2 stuff, some splinting that didn't release. So he should have been in 2 degrees, but I just went out, put him in 4. And I did that with other dents. So I learned the hard way. It's like, look, you start low.
No, I learned the hard way. You didn't learn the hard way. I learned the hard way.
And the other dentist learned the hard way, and I had to eat crow. I learned the hard way with the crow I ate.
Did not feel good.
No.
Especially if you've never had a history of any kind of back
That was
problems
what
or
like,
energy.
okay, I guess it was me. I couldn't, I'm like, no, what'd you do? It's like,
It was not
I already-
fun.
I already knew how to treat this
It
before.
blew me out.
So they go along with that. To me, they go along with the bringing the mandible down forward. As you bring the mandible down forward, I can increase the orthotics. We just had, we didn't get a chance to show it. We had a 65-year-old business executive. He runs every day on the elliptical. He goes to the gym. He's knee problems, and he had airway issues, and so I checked orthotics and I put him in a 2-degree correction. He wasn't, he's overweight, a little dumpy, kind of collapsed, and he had other things. He had problems, and so I took him, I put these in, and I said, well, keep checking.
I had my cell phone.
And he had some problems with the movement of the jaw stuff. We had some disc stuff, and he came in one day and he said, I think we need to change the orthotics. And I checked him, like, no. And he came back and he's like, look, I don't have any knee problem, my back's going better. So I checked him, he's like, yeah, and put him in. And literally, he went to 4 degrees and you could see him, he actually went blank and he stood right up. Because now all the stuff had gotten freed up. And it wasn't just the jaw, he had some other stuff, he was 65 years old. It was a little bit of dietary stuff and his lifestyle and stress. And the orthodontics, he had actually gone into the ALF stuff. So when the ALF got a little expansion, I could actually lift the posture more.
Yeah, the ones that we did.
His whole body would breathe. So that's a big thing with these. So, what's that? That's almost like 9 foot. Yeah. I'll show you the tasks I did.
So the idea is to start low, and then as the patient needs it, you're gonna add more to it to get to 4 to 5 to 6
Yeah,
to whatever you
I got
want.
this from this guy Simeon, who's an orthodontist in Australia. Came out and lectured with us 3 years ago. He had a podiatrist. They did this with a kid. But every 6 months they changed orthotic, which was another like $400 per set of orthotics. And I already knew about the system. And I thought, well, we can do that. That's easy because these things have discs that you glue on the bottom, the wedge. Where's my disc? I got this.
You were walking around with something the other day.
Yeah,
So
yeah.
I know you haven't.
Oh, and outside
I got some other. Why don't you come up? I'll let you use the demo. Take your shoes up. Yeah. What's that shoe you wear?
Yeah, sure.
What's that shoe you wear?
9.5.
Okay. So now, this is really came from, I was working with some other teenage tennis players that dads were fanatical, competitor, and he was taking the trainer and they had no core strength and they couldn't build core strength. And these girls were beautiful girls, but they were really feminine. They weren't the stouts, physical, stocky type. And I knew because they had both had knee problems that it was foot issues because I'd done the other stuff and they kept coming back. It's like, we gotta fix the knees because they have no core strength. And it was the same time period I was working with all this stuff with the orthotics. So, and he said, well, and they showed me they couldn't squat. They couldn't do a squat without knee pain, they'd collapse. And so what I figured out was that functionally, if you just tested the ability to squat, which is a core strength exercise, so you keep the feet flat on the ground, and you take the squat, and you go down as far as you can, you come back up.
Without lifting the heels.
Without lifting the heels off the floor. You know this already, Doc. You must be a chiropractor.
Yeah, it must be.
Okay. Feet even, parallel. He's got some pelvic issues. Turn down on one foot.
What was it?
I said, you must have pelvic issues. You got to turn down on one foot. Now go down as far as you can.
Ain't happening.
Oh,
Without the The heel's coming up there, right there.
No, only go to as far as you can without the heels go down. Back up. Go as far as you can right there. Go up and down a couple times there. See if you can get it to loosen up at all. Back up. Up and down. Up and down. Back up straight. Okay. Back up. Now turn toward me.
That's about it.
Turn towards me. Now hold this up. Hold. I don't do muscle testing. All I ever do is strength evaluation. I don't like muscle testing because it's too subjective. Not that it's invalid, but for me, I prefer to. It's more convincing to the patient. Hold this. Hold. See you next year. Show me stronger. Come on. Try again. Hold on. Okay, roll the pelvis. That's a screening. That's a pre and post test. Everything you do in SOT is about pre and post. Do we make changes? Okay, now, strength test. Strength. That's all I do is strength test. I don't do muscle testing. So he's got both feet flared out. All right. So these are 8.
Wait till you see your next one, Richard. I stood up against the wall, take pictures, and his feet are like that.
Yeah.
I mean, they're moving way after I'm going, that's it, you're going to Richard right now. You know, do not pass go, just go straight to Birdman.
And watch.
Okay.
And now do your squat again. What happened?
Yeah. Not bad at all.
What happened?
Awesome.
Did I make a change?
Yeah.
Do I have to sell him on that?
No.
Do I have to sell the parent on the kid that does that? It was so funny. I had 2 kids there, and he said, "Well, why am I going to buy these?" And he's literally on his phone with his wife. It's like he wants $225 for these orthotics, and he goes, "Never mind." Click. Pulls out his checkbook and he starts writing the check because of that test right there. Because the kids stopped, knees stopped hurting, and all of a sudden they didn't go that. They went all the way to the floor. It's like they're shaking. Okay, and I put them in. They went. Okay. All right, sold. It's done. Hold this. Hold this. Hold.
Well, you want to just meet Mom and I at the start,
Right.
down the elevator, this
How
elevator.
hard am I pushing?
There's just
Harder.
right there.
Back up.
Like if you walk out the elevator. to
Oh,
the
the bottom
left.
of this elevator.
The bottom
Hold
of
it.
this elevator, yeah.
Uh-huh.
The sad part about this is I wear
Is that okay
orthotics.
for you?
Yeah,
And they're most of the time they're wrong.
They're wrong.
Because
Yeah.
it's the entrances and I
Why?
think
Because
it's
they work off the
right
premise that
out
it's
here.
just a foot problem. Is it just a TMJ problem? No.
Oh, I know, well, you guys made
They
it.
need us because we do all our stuff. Well, same thing with the photography. Why is that any different than this?
You see, the casino's only 2-story. This is
Have you
the,
ever found that?
this is the
like,
residential tower.
your orthotics are strong, but once they open your thighs and the shoes, if the shoes are bad?
Oh, yeah. Oh, yeah.
How do you recommend
Yeah, so you
square or like?
Yeah, so go ahead.
Yeah.
See you in a couple weeks from now.
Yeah, thank you very much, Richard.
And I have.
Doc, how
And
did
if that doesn't work, then I build up the orthotic with these.
Oh, absolutely, that's why, what does that do?
It builds a wedge. It's a wedge. I know.
And you put them,
where do they go?
on their orthotic with that. Build up the wedge.
When you looked at him now, how did you figure out that was the measurement when he did his test? What you were just looking at the arch and how did you figure it was an 8 or whatever?
A mentalist.
You just okay.
No, it's whatever makes the correction. That may not be his exact correction, but he
Okay.
improved his neurology, so I went in the right direction.
Okay.
So, when you're good, you get lucky a lot.
Okay.
Because you're close when you guess.
And you just have a whole bunch of samples and a kit, and you just play around with
At this point, I actually just take the orthotic and go, here, this is what you're going to wear. And then, 2/3 of the time they sell themselves.
it. Cool.
90%.
And these are about 240?
I charge $225.
225.
I think Dr. Walker charges $250, but she always sends them out and gets the correction made in the factory so that there's no discs. I actually just glue discs on.
For the longest time, I'm thinking I've got something wrong with my quadriceps. They're so weak.
And that foot.
I should know. I mean, I tell patients this all the time.
5 years ago, I used to use foot levelers, and I had them made me a pair, and they canted me backwards wrong.
Yeah.
And I couldn't figure out what was wrong. I had just chronic issues. And I'm like, that's it. I'm not having anyone else do orthotics for anymore. That's done. I'm done with that nonsense. You're done.
Yeah, and that's part of the reason I think for those of you who got a chance to see him the last couple of days, I think you realize you were listening to somebody that's pretty special. He is, yeah. But one of the reasons he is so special is because when you practice an environment like that, he has to play all the roles Okay, we don't have, and he tells me all the time, because he's in my office every 3 months, and that's one of the reasons I do a lot of ALF therapy, because I've got the master in my hip pocket every 3 months, and that's a big advantage. And when you're doing that kind of stuff, you really need that. ALF is really, there's a lot more to it than it really looks like on the surface sometimes. So it takes you a while. I'm sure Rebecca knows that too.
Well, my learning curve was about 7 years.
Yeah, right.
Until I felt comfortable with
Yeah.
it. And then, I've been at it for like 15.
Right. Yeah. And I know even for myself with the ALF, when I first started working with some of the earlier cases, especially with the kids, where the inclination is to use a banded ALF so it's cemented in place. One of the things I was doing at first was going through the pains of putting the ALFs in and not cementing them in, because I wanted the ability to take it out, make those bends in my hand so I could see what that wire was doing before I put it in. And then you put it back in. So I used a lot more cribbed, ALFs at that time. But there is a learning curve with those things. And so once you get to the point where then you start adjusting it in the mouth, and then you take it out and see what kind of a pretzel it looks like that you've done, and realize, oh, okay, well, I think I spent probably 2 to 3 years doing that before I use cemented ALFs. Leave them in, just adjust them right in the mouth, learn to feel the head a little bit, and the work goes on. Okay, so this is one that's been stated a lot of times before, and I think this is the one thing that that really got us going, is that we realized, and I think this was promoted. Even we heard this from Jim Carlson, and we heard this from people before us. The cases that are really difficult dentally, sometimes are just no-brainers for the chiropractor, and vice versa. And so obviously that made our ability to work smarter, not harder, really go to work. Okay, so. Again, we've gotten kind of ahead of ourselves with a lot of this stuff, and so it may get a little bit redundant, but obviously working in the co-treatment, the benefits to the chiropractor, like I say, we've stated most of these. Access to the patients, benefit from the advertising budgets of dentistry, which are usually much larger than chiropractic. That's interesting. I think basically because this is Richard's slide, I think basically what this says is that because I put on the study group and I go through all the expense, all the preparation, all the work, and he gets the benefit.
And Razi does, huge marketing. He goes out and he does his lunchtime lunches with dentists and oral surgeons, and I just show up and what do you got for me?
I know. Yeah.
And then the ones that live anywhere between his office and mine end up getting referred to my office anyway. So the benefit really is that, because it doesn't matter who I'm working with, they're doing more marketing than I am, because I don't have to really do it, because for me personally, I've created a lot more dependence on.
This meeting in November is going to be presented by an orthodontist down from Orange County who specializes in what he calls terminal cases. When everybody else has given up, he's the one they go to. And we're going to hear about birth to 5 years of age only from him. How many orthodontists treat kids less than 5 years of age? So,
but how many of you?
Yeah, how many of you are there? Not very many.
And count the clones.
Right. Yeah, not very many. So, okay. And then this is where I think we really want to go in the future, is that, once we've got them physiologically stable, we've got them out of this, mode of this chronic pain and all that kind of stuff. Well, they feel a lot better, but they're still not, whole again. They're still not completely there. And so now we take a look at some of the other modalities, some of the other therapists that are out there that can help enhance, their physical and mental well-being. And that's and to take them to whatever level the patient wants to go to. Okay, so why co-treatment? And I think already we've touched on pretty much all these points already here in just our discussions. It's it's pretty plain and obvious. It simplifies things. It provides us access to these different markets, because we've got all these people in this arena, whether they've come from the study group or they're actually in the group that's actually treating an individual patient. Right now, I've got one lady that I'm treating that we've got 2 dentists, an oral myologist, an osteopath, a chiropractor, and Kathy Lippman, an environmental medicine specialist. Okay, so this lady's got 6 people working on her, and I mean, this lady was, was headed for the suicide, ring, and now she's not even thinking about that within just a very short period of time. But I know that by myself I couldn't turn that around that fast. I know that probably with even 2 or 3 of us working in that group, we couldn't. And so it makes it a little crazy in a way to be shuffling with that many people, and especially having 2 dentists on board. But we're kind of doing that really more as an experiment, because he comes out of a totally different model than I do as far as correction. And so we've kind of talked and agreed we want to stay on board, because I want to learn more about what he does and how he does it, and vice versa. And so again, there's more learning, and that's what this is all about. Okay. And this one here, the last one, this is probably the best one of all, and get rid of the limitations we have in our treatment is so important. Okay, now I know what to do when we hit that wall. Okay, send them down the street, send somebody else.
And part of that too, if you talk to Derek Nordstrom, he'll tell you one of the things he loves about Hollister, but he hates what he doesn't have a big enough network. He can't get enough doctors, chiropractors, other people that work with him. That's part of why he travels so much. He travels to osteopathics office and works in their office treating them, their family, and some of their patients, and that's partially because of that. He doesn't have the network in that smaller town, and so he makes comments about how great it is, what we really have in our network, because we have so much access to your clients.
All right, so this is what we're going to talk about, and pretty much this model is going to be based upon what Richard and I have been doing for however many years it's been now.
Well, how long have you been in Montrose? 5 years?
I've been in Montrose 5 years, and we've been doing it long before that.
But I mean, so it's actually being in the same location for 5 years.
Yeah, right. Well, it's only since I moved to the current location that we've really done the in-office, because we had no facility for him before, which we'll see. So let's go through it, and this thing's going to work. Okay. So in the past, and this is as of a couple of years ago, whatever, this is what we were dealing with, where it's just pretty much the 2 of us dealing with all the issues that we had to deal with. And my orientation, of course, is doing the orthopedics with orthotics at night, orthotics during the day, whatever the case may be, whatever the patient needs, and feeding off of what he's feeling and sensing. And we communicate in some fashion or whatever, but in separate facilities. So the disadvantage is when a patient comes in and they are still symptomatic on an orthotic that I'm preparing for them, then it's, okay, is it my turn to play, or is it my turn to send the patient over to Burbank to see Richard? And this is the one thing that long before I met him, I was doing a lot of orthotics, a lot of TMJ treatment in the past, and it's always about the plastic. I'm always battling, how am I gonna get rid of that little pain they have in their joint, or that neck problem, because something's obviously wrong with my orthotic. Okay. So we tinker and we tinker and we tinker, and that's what this whole paradigm helps to eliminate, is a lot of that tinkering, because I'm gradually learning that when is it his problem to fix, and I leave my plastic alone, so that's made it a lot easier. Okay, so this was the result, is that either it takes a long time, or we don't get the best result. We don't uncover some of the other issues that are going on with them.
And just like and one of the things is that with Olmos' model, it was 5 years ago or 6 years ago when he started doing those residencies. I came down the first year after he came here and spoke, because he was trying to figure out what this chiropractic stuff could do for him, because he hadn't had any chiropractors that really helped him yet. And so when I went down, I did the whole cranial thing on him, and it was instantly, this is how you make it easier. And the reality is having that feedback, that how do you release the system to the orthotic, because the system's in that sympathetic overload, or that state of stress. So it just made a whole nother step, or another whole moving forward after that because of that relationship. And it's really
Just
the
don't
same
kick the
thing
can.
Norton talks about. Appliance needs to be checked cranially to make sure that it matches. And if it doesn't, either you can release the system to the appliance or you need to change the appliance to match the cranial function, which is a little more Nordstrom's model. But if you're doing the neurology, you're actually coming close. A good way to do it because it just has a very low-key sales or promotion about it because you're trying to teach people and they're coming in and presenting. We asked the oral myologist will come in and present what they're doing. The cranial sacral therapist came and talked about what she was doing. And the oral surgeons presented, and so everybody rotates through, and anybody who wants to present can present. And we all learned something. That's the oral surgeon stuff was like watching the video, all the slides of the oral surgery. It's like, okay, I don't want to do that. I'm just cutting up the face in the middle of a fourth procedure. So it's really, well, I thought he was crazy for keeping the meeting going for that long because we lost all the dentists, and all of a sudden I realized, wait a minute, it turned into something that's really better than I could have ever imagined.
Yeah.
And most because he kept persisting that we should be doing it, and I didn't really, I was like, we're running, there's nobody left to teach, and we're not really learning from each other anymore, but all of a sudden it was this, it exploded in this whole new arena just because we kept doing it.
Yeah.
And it just grew on its own almost.
Yeah. Certainly as a practice management tool for developing a referral base and everything. The study group is an excellent way.
We have people driving in from Camarillo, Ojai. They've driven up from South Orange County.
Yeah.
So we've had people drive 50, 70 miles to come to the meeting.
But they only do it once.
But still,
if you're coming that far in LA at rush hour, you know, it's 2 to 3 hours.
But still, it made the network grow. So it's really, I think, should be part of what, if you're going to do it, try to do it, because I never liked doing lay lectures. I never liked having meetings and trying to hustle people to come to teach them about what I do, but it's exactly what this turned into. But it did it in a way that was so, it was seamless. It was just like, yeah, we're still learning it, so people actually coming in to try to get us to send them patients. But in the process, we just grew our network, our referral base, because they go, oh, because that Michelle Razor case, when I showed on Thursday, we were at the meeting, and it was, he brought her in, and it was like, okay, what are we gonna do? Let's see, and everybody, I mean, I'm talking about everybody took off and did their analysis of her before I ever stood up and said, okay, let's see. And I knew if I put the belt on her, that was really gonna be a big deal, but I knew the orthotic was part of it too. So it worked out better than I could ever plan it, because that was completely unrehearsed, that whole video, because it was just like, I think that's this here much. And we ran with it, but God, everybody in the meeting was like, what did you do? I mean, it was like you could just see the faces just change. Like to know, I knew something before, now I know nothing.
And that is another advantage, and occasionally we do that. And when I first heard about this lady, I go, okay, this is, you know, she's got way too much stuff going on for me to take her on, especially when she's going to travel, you know, 2.5, 3 hours to come see me. Okay, and so having a group like that, you just, you know, your level of confidence in being able to help that patient, whether I wind up doing it or whether somebody else does, doesn't really matter, but all it does is it just raises the self-esteem of the group as a whole, as well as all the individuals in it.
And on the underline, everybody keeps seeing how structure, whether it's dental or the two of us or the chiropractic part, that structure keeps being fundamentally part of every case, that it's really dramatic. So it sells itself. I mean, they just kind of go, oh yeah, okay, that's really, okay. They keep nodding their head. I get it.
Okay. So this is pretty much, you know, this is pretty much the present state, and this is obviously our future, is just continuing to do these things, learning, you know, from all these people that we see. And in fact, this, our next...
So that it really is made, from what I can see, in Nordstrom's model, it was essential from the beginning, and now it's becoming essential in the dental TMJ and neuromuscular, not neuromuscular, but the motor reflex type of work that Olmos teaches.
So where we've progressed from there, as we've started working in-house and everything, is that we've also been working with Dr. Nordstrom and Dr. Moreno, the osteopath, who you heard yesterday and the day before. We've included some other therapists in the system, and obviously the results is that you have a higher success rate, you travel through things a lot faster and easier, because you know it's not about your plastic anymore, you know it's about some of the things that may be emotional things, that may be past history traumas, things like that. And these other people help us figure all that out. And so a lot of times I'm just kind of reduced down to a mechanic, and which is kind of nice because I get to turn my brain down a little bit. I don't have to work quite so hard. Okay. But the other part of it, you know, from what we get at the bottom end of this, of course, is that now that we're working in a network, you know, all these people are referring to me, and I'm referring to all them, and so it's a whole paradigm that works well for everyone.
Do you have a slide about the DCO group in here? Did you put a slide about the DCO group?
No, I don't think so. I'll have to watch and see. I can't remember now. Okay. So, and then we're going to talk a little bit about the future, and of course that is that as our study group, okay, which is what he just mentioned, which I don't think I put a slide in here about them, and that's part of what we did is that even before I left my old office, we got a study group going because once he and I started working together, we realized that, boy, there's a lot of information. You know, everything you learn, you realize there's more that you don't know and you don't understand, and so you have more questions, and so we need more resources to answer those questions because...
Okay, so the study group is the osteopath and the chiropractor?
Right, the study group is a multidisciplinary group and include all those people.
What started off was, when we did, he started off 10 years ago being just dentist and me and a couple chiropractors trying to get more chiropractors in the group and get more dentists that were referring, so it was like I was trying to teach them what I did, and they were trying to, you know, figure out each other what they were doing at TMJ. I think it was really early on. But in the last 2 years, it's turned into a practice management tool. It's really become a kind of a lay lecture. We get people, like the patient came in, they'll just come in because one of the practitioners invites them in. And so now we've got practitioners, speech pathologists, all kinds of people that want to come see what we're doing there because just the network has grown. It's like, oh yeah, these guys, you know, they have this weird thing they do. But they want to be part of it now because the oromologist, the speech pathologist are more regular than any of the dentists. Him and I are the two of long-standing people in it, meaning that it became just strictly a meeting about our dental cranial program. And a couple of the other dentists come in and out, the oral surgeon comes in and out, but we're the core of the thing. It always has been his office, and now we just moved into the hospital nearby. So to me, it's become the best practice management tool I've ever really had. And for this model particularly, I think it's really